Right. Is everyone here? Shall we start? Okay, guys, turn your cameras on. Okay. So today, Kavin is here. If you all have any issues with the cameras, just drop him a message. Huh? Okay. Right. Okay. So today we are going to talk about growth hormone. Some very interesting things. Some very there are some very confusing things, right? Let's see. Okay. Firstly, let me share the screen, guys. Until then, can someone tell me what do you all know about the word acromegaly? What do you know about this word? Anything you know about it, just let me know.
Excess growth hormone secretion.
Right. Okay. Anything else?
After puberty.
Despite
Good.
growth occurs despite there is closure in the epiphyseal plate.
Right. Good. Okay. So you all have some idea, right? Can you all see the screen, guys? Give me a second. Right. There we go. Okay. Right. Look at this, guys. So we'll start off with the basic physiology, right? We'll start off with the basic physiology, then we'll go to the disease, right? So we are mainly going to talk about acromegaly and gigantism today, right? These are growth hormone related diseases, right? Now, the first thing, guys, we'll dive into the physiology of growth. What is this growth, right? Growth, guys, when we say growth, usually in humans, we talk about two things, growth and development, right? We talk about these two together, right? Growth, right? Just like this says, an increase in size of body structure and maturation of physical body size, right? The physical things is what we call as growth, right? So we will be seeing changes related to height, right? Changes related to thickness of bones, right? Size of viscera. We will talk about all of these kind of things. Development is what, guys? This is maturation of cognitive and psychosocial abilities. So here, basically, we are talking about mental things, guys. When we say development, we are basically talking about mental things, right? Right. So one of the first methods, guys, that we used in the world, right, to assess this physical growth, right, is this thing called, draw this, guys. You all can draw this somewhere here if you all have space, or you all can take a new piece of paper, right? There was something introduced, guys, called the height for age curve, right? This was called the height for age curve, right? Yes, okay, give me a second, screen is stuck. Okay, can you all see this? Yeah, okay. Height for age curve, right? So in this axis, we put the height, right? In centimeters, right? And here we put the age in years, right? Age in years, right? Okay. So this was founded by someone called Richard Scammon, right? So what he proposed was that humans, according to their age, there are some changes in height that we can expect on average in the human population, right? So this is what he drew, right? So when he assessed it, guys, right? When he assessed it, it came off something. You all can draw this, guys. It started off somewhere around. We can't be born at zero height, no, guys. We can't be born at 0 centimeters, right? Okay. So we are born at about, usually, guys, at around 50 centimeters, right? We are born at around 50 centimeters, right? And the scale goes up. Usually, on average, humans don't cross 200, right? 200 centimeters. There are some exceptions, but not very common, right? Not very common, right? And then in the years, guys, you just put this, we'll go 2 by 2, 2, 4, 6, 8, right? Let's go 20. Let's go until 22. Okay, 22, right? And here's the special thing, guys. On this right side corner, draw another line, right? Draw another line, right? And this one, we will look at the percentage of total growth. Percentage of total growth, right? Percentage of total growth. Okay. Now here, just mark it from 10 to 100, guys. 10, 20, 30. These are percent, huh? 40, 50, 60, 70, 90, 100, 100%, right? Okay. Right. Okay. Now look at this, guys. Now we will draw this general growth curve, right? This general growth curve, guys, it is basically, this growth curve was introduced, this height for age curve. It was based on physical body structures and the visceral sizes, right? Physical body height and visceral sizes, right? So this curve applies for all of these. So it looks something like this, guys. What I want you all to do is, when you all are drawing this, right? When you all are drawing this at around 2 to 2.5 years, right? At around 2 to 2.5 years, take about 25 to 30% of growth. I want you all to get this curve like that, right? Somewhere there. Okay. And then again, at around the age of 12, right? At around the age of 12, go for about 60% of the growth, right? The curve looks something like this, guys. The curve looks something like this. Initially, there is a very rapid one. Then it slows down a little until about the age of 12, and then increases again, right? And then comes to a plateau, right? This is what the curve looks like. This last bit is a straight line, guys. Okay, draw a straight line. Huh? Last bit, draw a straight line. 100, yeah, straight line. Okay, right? Okay. So this is the height for age curve, right? That was proposed by this Richard Scammon person, and later the percentage of total growth was also added to this, right? So now we can look at several things here. Look at this, guys. What does this graph show now, right? The first thing I want you all to know, look at this. From start to the stop, from start to the stop, right? Humans' growth is a continuous process, right? Humans' growth is a continuous process. What does that mean? Do we see any period where it's growing like this and getting straight and then increasing again and then getting straight? No, right? So there are no periods of growth completely stopping, then growth happening again, then completely stopping. No, right? Humans' growth is a continuous process. It keeps on increasing until the very end, right? That's the first point I want you all to know. The second point, guys, what I want you all to know, it's not a linear process. What do I mean by that now? What do we mean by a linear process? Usually, if it is a straight line like this, right? Usually, if it is a straight line like this, we mean it's linear. What does that tell you? If it's not linear, guys, what does that mean? Humans don't have the same amount of growth per given amount of time, right? That means all humans, we cannot say between the age of 4 to 5, all humans will grow by 2 centimeters. We cannot say that because it's not linear. Okay, it's a non-linear process, right? Then the next thing, guys, there are 4 main phases. There are 4 main phases of growth, right? Now we can see this here. The first one is, guys, called our first growth spurt, right? Growth spurts are what, guys? These are periods of rapid growth, right? The first growth spurt, guys, is here from the time of birth, from the time of neonatehood, right, up to around the end of the toddler period. You all know, guys. Okay, how do we usually do this? Birth to first month, right? Birth to first month. What do we call them? Neonate, right? We call them neonate. Then from the first month onwards up to the 12th month, basically up to the first year, what do we call them? Infant, right? Infant. Then first to the third year, what do we call them? Toddler, right? We call them toddler, right? Okay, so somewhere between this, guys, usually we say between from birth to around 2 to 2.5 years. Somewhere there is our first growth spurt, right? Our first growth spurt. Okay, right? This is our first growth spurt. Then, guys, after the first growth spurt, as you can see from this graph, right, the rate declines a little. The growth rate declines a little, right? But does it stop? It doesn't stop. Huh? We are continuously growing, but it declines a little, right? This is, guys, early childhood, somewhere between 3 to 12 years of age, right? The growth does not, there is no spurt. It just continues at a normal rate, at a continuous normal rate, right? At this period, guys, there is no growth spurt. But what I want you all to know is by the age of 12, we reach about 60% of our total growth. About 60% of our total body growth is reached by the age of 12, right? By around the age of 12, not exactly 12, around the age of 12, right? After that, we get our second growth spurt. This is the adolescent growth spurt, guys. This is basically our puberty, right? The pubertal growth spurt, right? So this is this one, right? Now, puberty, the onset of puberty, guys, you all know this varies, right? In girls, it's a little bit earlier, right? Somewhere around 12 to 14 years of age for girls, right? And then for boys, it's about what? 14 to 16 years of age, the onset of puberty, right? So this age can vary a little between the sexes, right? But there is our second growth spurt there. Okay. Now, so this is the third one, guys. The third one. Now the fourth one and the final stage is called the asymptote growth state, right? What is this asymptote, guys? It's nothing much, right? It is how we define the flat line, right? After puberty, humans cease growing. Okay, humans cease growing. Do you all know about rats? What happens to rats? Rats never stop growing. Do you all know that? Rats never stop growing. But the thing is, their lifespan is only about 1.5 to 2 years, maximum that, right? So you don't usually see giant rats, right? Unless there are some mutations or something. We don't usually see giant rats, right? Otherwise, now, have you all seen there are some conspiracies about this, saying that humans are polluting the environment and we are feeding rats, and there might be mutations expanding their lifespan, so that in the recent future we will see giant rat invasions. Huh? Okay, so who knows, right? Okay, humans stop growing. Huh? Humans stop growing. Just know that. Now, this stoppage of growth, guys. This is also related with the end of puberty, right? End of puberty also, you all know. So girls, they start the puberty early and they end it also a little bit early. Around 16 to 18, puberty is over in girls, right? And for boys, around 18 to 20, right? There can be slight changes, guys, right? But this is the average. Right? Okay, did everyone understand this, right? So this is how we assess the general growth of humans. Okay. Then, guys, look at these two graphs. The first one, right? The next thing what we are looking at is the height and growth rates, guys, how they vary between the sexes. Right now, as you can see, right, look at this. This axis is showing is the height gain, guys. Okay, height gain, not height, right? Gain of height, right? Look at this, around 0 to 2, right? We have the first growth spurt, right? But still, as you saw here, guys, what happened? This growth spurt, it little by little the rate reduces. Little by little the rate reduces, right? So that's why it's coming downwards like this. That's why we can see it coming down, because the rate is reducing, right? It reduces, guys. What I want you all to know, in the infancy and early childhood, the changes between boys and girls is very minimal, right? But the changes begin to start during puberty. That's when the changes in growth starts, right? So here, as you can see, right, the height gain. The first thing I want you all to notice, guys, look at the slope of these graphs. The girls one is something like this. The boy slope is much more steeper, guys. Much more steeper. Can you all see? What does that tell you all about the growth rate? during puberty who is growing at a faster rate?
Boys.
Boys, right? Boys usually grow at a faster rate. The other thing is, guys, boys grow at a faster rate. Y'all can write this down, right? During the puberty lasts for how long, guys? Roughly how many years? Roughly around 4 years, roughly around 4 years or 5 years max. 5 years max, not more than that, right? So girls, guys, during puberty, they can grow about 2 to 3 centimeter per year. Per year. For all that 4 years of puberty, let's say the puberty lasts 4 years, per year they can grow 2 to 3 centimeters. Boys, guys, boys, they can grow about 5 centimeters per year, right? Okay, right? So boys, for the same year, they gain more height during puberty, right? That's the point I want you all to understand there. The next is, guys, the growth of various different types of tissue, right? Okay, look at this. Here we have the 100% line, right? Draw the 100% line, right? This is 100%, right? Look at this, guys. What is this yellow one? Is the one that we talked about. This yellow graph is the one that we already talked about, the normal height for age. This applies to body organs and body viscera and height, right? Body and most visceral organs, the yellow line that we already discussed, right? Look at the brain and head, guys. The brain and the head, the dark blue line, right? Can you see? We reach about, look at this, guys. We reach about 90% by the age of 6. By the age of 6, we reach about 90% of our total brain size and our head, right? Head, of course, doesn't increase a lot, right? But the brain size is very important, right? We reach 90% of the brain size, okay, by around the age of 6. Then look at this lymphoid tissue, guys. This one is special. Lymphoid tissue, right? From childhood, right? Until puberty, it increases, it doubles in size, right? Then once puberty is onset, it actually starts, this lymphoid tissue starts atrophying and coming back to the normal adult size, right? So it goes to 200%. It goes all the way to 200%. Then it starts atrophy, right? And coming to adult level sizes, okay? This is very special, right? The lymphoid tissue is like that, okay? Right? Then, guys, look at the light blue curve. Reproductive organs, right? Reproductive organs, guys, look at this. Until about the age of 12, right? Until puberty hits, less than 20% will develop, right? Look at this, less than 20% will develop, okay? Less than 20% will develop, okay? Soon after puberty hits, what happens? There is a shoot, right? All the way to 100%, right? All the way to 100%. Here, guys, an important thing. You all can draw a dotted line like this, extending from this blue graph, right? And draw something like this, guys. What is this, right? This is for females, guys. Females after menopause, right? There is a general atrophy in reproductive organs and tissue, right? Okay. For females after menopause, there is a general atrophy of reproductive organs and tissues. Okay, right? That's after menopause. Now this graph is only until the age of 20, right? So that's why we drew it in dotted lines, right? This is after around the age of 45 to 50, right? Okay.
Wait, Prashan, does
Yes.
the increased lymphoid tissue size does it?
No, this is normal. This is normal physiology. Yeah? This is not any pathology.
No, I understand that, but how does it manifest in any way? I mean, isn't it weird for it to be more than 100%?
No. That is how it is. That's why it doesn't manifest in any pathology. It is not any disease. It is how so the clinical thing would be, guys, after the adulthood also, some lymphoid tissue, if they continue to be large, then there can be a problem. That is your clinical point to understand that. After they finish their puberty, right? Once they reach this place, guys, this is normal adult size, right? Okay, so during
So
Yeah.
supposing there is some sort of infection during that period, would the lymphoid tissue increase even further than that?
During what period?
This period when it is increased more than 100%.
Yes. Yeah, but this period it is increased more than 100%. It is still normal, guys. It is still normal. It will increase beyond that. That's okay. So a child, if a child gets an infection, yes, there will be some lymphoid tissue. There will be some swelling, right? But that is for their age. That is the normal, right? The problem is to judge lymphadenopathy and other lymphoid tissues based on even if you look at the thymus. You all know thymus is barely seen in adults, right? Why? They are supposed to atrophy. That is how they are supposed to be, right? That is their normal size in adulthood. Okay, clear? Right? It's not a pathology, huh? This is normal. This is normal, right? They will do their normal function. It is how it is. Okay. Don't think it as a pathology. It is normal, right? Okay. Right. Then, guys, factors affecting the growth. Factors affecting the growth. Look at this, guys. Genetic factors, guys, right? So these ones we are not going to talk about in depth, guys. There are a lot. Okay. One of the most common, first thing, tell me this, you all must have noticed, if there are children of very tall parents, right? The children also are more likely to be tall stature, right? You see it, no? But there are exceptions. Sometimes very tall parents, very short children can be possible, all right? A condition that you must know, guys. You will learn this more in pediatrics, but you must know this. That's so I'll mention this is achondroplasia. Have you heard this? Achondroplasia, right? This is a genetic defect, guys. This is an autosomal dominant defect, and sometimes it is sporadic as well, right? Sporadic as well. What we see, right? This is a point mutation, right? Point mutation. What happens is, guys, these children fail to elongate their bones. Now, today, during the pathophysiology, we will see how elongation of bones happens, right? In these children, that mechanism is going to fail, right? So their bones, there is something called endochondral ossification, guys. We will talk about this, right? Endochondral ossification does not happen in achondroplasia, right? Okay. Best example for you all to remember, have you all watched Game of Thrones, right? You know this guy, right? Right? Tyrion Lannister. So he also suffers from achondroplasia, right? If you all want to remember the features, just remember him. They have a disproportionately large head, right? Body is very much smaller, right? There are a number of features, guys. Their reproductive functions and everything is normal. Those things are normal. It's just a problem with the height, okay? And their brain function is also normal, okay? Right? Okay. Right. Then environmental and nutritional factors, guys. These ones are obvious, no, guys, right? Environmental and nutrition you all can obviously understand. We need certain, especially, guys, iron, right? Zinc, phosphorus, right? Iron, zinc, phosphorus. Then if you take vitamins, right? Vitamin D and A, these are essential for growth, right? Essential for growth, right? You all must have heard protein energy malnutrition disorders, right? Kwashiorkor, marasmus, have you all heard about, right? So nutrition is very important, right? Apart from that, guys, environment, what we are talking about is, guys, most of the time we are talking about diseases, right? Diseases. Just know, guys, especially in childhood, chronic diseases in childhood, right? It can be something like asthma, right? It can be something like thalassemias or iron deficiency problems, right? Whatever, right? In chronic diseases, guys, especially in childhood, it can cause temporary depressions of growth, okay? Temporary depressions of growth. Just note that down, okay? In childhood, right? Chronic diseases, temporary depressions of growth. I will tell you all why it's temporary when we come to point number 5, okay? Then hormonal changes, guys. Hormonal changes, we'll leave it. We'll come to it at the end. Go to point number 5, catch-up growth. Catch-up growth, right? This is what we were talking about, guys. When, look at this. Let's draw this. Let's draw this. Let's draw a graph, right? Again, we will draw our normal height for age curve, right? It looks something like this, no? Right? It looks something like this. This is a normal child's N, right? Normal child's height for age curve, height for age curve. When a child has a chronic disease, guys, when a child has a chronic disease, right? Let's say around the age of 4, they got some chronic disease. So he will come along like this with the normal child's range, and then their growth will reduce. The growth rates will reduce drastically, right? Growth rates will reduce drastically. Okay, then let's say at about somewhere around here, at about the age of 8, he was cured of this disease. He was cured of this disease. What happens is, guys, right? Humans and some other mammal species as well, we have the capability, once that stress factor is removed, we have something called catch-up growth that allows humans to reach the normal range again, right? Especially this is in childhood, guys. Especially this is in childhood, okay? Humans have this function called catch-up growth. They can alter their hormones, we will see, right? They can alter their hormonal balances and improve on that lost growth, right? Throughout the months, the growth that they lost, right? Okay, right? Clear? So that is catch-up growth, right? Keep that aside. Look at this, guys. Hormonal factors. What are these hormonal factors, right? Hormonal factors, guys, there are several things I want you all to know. Look at this. We have drawn it here. All right. The first thing I want you all to know, right? During our infancy growth spurt, right? What is this infancy growth spurt? Our first growth spurt, right? We said somewhere around from the birth up to around 2 to 2.5 years. This is the infancy growth spurt, right? In the infancy growth spurt, guys, the major hormone involved is thyroid hormone, right? Thyroid hormone is the major player, plus growth hormone plays a small role. Huh? Write it down. Thyroid hormone is the major player. This is why we mentioned, right? We didn't discuss it in depth because this is under pediatrics. A child who is suffering from hypothyroidism, they can develop a condition called what? We talked about, remember? Cretinism, right? So thyroid hormone is essential, right? During this infancy growth spurt. The second one is, guys, during around 4 to 12 years of age, there is a continuous growth period, right? No spurt, but just a continuous growth period. In this one, guys, who plays the major role? Growth hormone. Growth hormone plays the major role, right? And thyroid hormone can help a little. Okay, thyroid hormone can help a little, right? Then finally, guys, our puberty growth spurt, right? Puberty spurt. In puberty spurt, guys, who plays the major role? Androgens and estrogens, right? Androgens basically are progesterone and our testosterone, right? And estrogens, they play the major role. You all can put growth hormone helps, right? Growth hormone also helps, right? Okay, growth hormone also helps. Okay, right? Now look at this, guys. So what can you see? Throughout growth and development, right? Growth hormone helps in some way or it plays a major role, right? Growth hormone helps in some way, either it's a minor factor or especially during the 4 to 12 years of age, it is the major one. Right? Okay. Everyone understand these concepts. Now we are going to take these for the next few, for the disease especially, right? Very important, right? Okay. Now here, guys, just before we move on, right? We said girls reach puberty a little bit early, right? We said girls usually around the age of somewhere between 12 to 14, they can reach puberty. They can start puberty, right? Boys around the age of somewhere between 14 to 16. Now, have you all heard the term Precautious puberty, right? Precautious puberty. What is this precautious puberty, guys? What is precautious puberty? Right? You all can just write it down. Precautious puberty. What is precautious puberty? Anyone? Just from the name?
It's before the age of puberty, like normal age.
Yeah, not yeah, good. Before the proper age, right? Before basically precautious puberty is puberty that is starting, right? Before the actual age that it was supposed to start at. Right? So depending on the country where you all practice, guys, they might have different guidelines for this, right? In some countries, they say for boys, if puberty occurs before the age of 9, sometimes they say that is precautious, right? Okay, for girls, sometimes it's a little bit less because girls reach it a little bit earlier anyway, right? So around the age 8, 7, right? Sometimes. Okay, so the actual definition can change, but what we need to know is before actual puberty, if pubertal features start appearing, secondary sexual characteristics start appearing, that is precautious puberty. Now tell me this, guys. Look at this. When we look at growth, right? Infancy, mainly thyroid hormone, growth hormone helps. 4 to 12, mainly growth hormone. Puberty, mainly androgens and estrogens. If I am asking you all this question, right? Growth hormone plays a role in precautious puberty. Now look at this, guys. When I say puberty, I am only talking about the secondary sexual characteristics, right? The onset of secondary sexual characteristics and the related changes, right? If I give you all a statement, growth hormone plays a role in, or growth hormone helps to cause precautious puberty. True or false?
True.
Right. Here's the thing, guys. Right? Right? This is false. Right? This is false. Here's what I want you all to know, guys. When we say puberty, don't think about the physical growth in height. Don't think about physical growth. Think about secondary sexual characteristics. Think about only that. Right? Growth of reproductive organs, the size, right? Appearance of hair, right? Pubic hair. Think about those things. Right? This precautious puberty, guys, right? It only works with these androgens, with the androgens and the estrogens, right? Growth hormone does not play a role. Okay, please note that down. That is a very common ERPM question. Okay, right? I will give you all the true or false question towards the end. Okay, right? You have to put it as false, right? Okay, right, guys. Now we will move to the growth hormone. Give me a second. Right, look at this, guys. Growth hormone. Right, you all can put the topic. Growth hormone. Right, look at this, guys. The first point I want you all to know, write these down. All other anterior pituitary hormones, guys, they worked on glands. Do you all remember? Right, all anterior pituitary hormones. If you take TSH, where will it go? It will go to the thyroid gland. Right, ACTH, where will it go? Adrenal gland. Right, LHFSH, where will it go? To the gonads, ovaries and testes. Right, so all of them work on glands except growth hormone. Growth hormone exerts its effect throughout the body, guys, on almost all tissues of the body. Write that down. Growth hormone exerts its effects on almost all tissues of the body. Okay, unlike other anterior pituitary hormones that we have talked about. Right? Okay. Right. Then more points. Okay. Right. Then, guys, the next thing I want you all to know, right? Just some points, some biochemistry points for you all. This is a peptide hormone, right? It's a peptide hormone. So if it's a peptide hormone, can it directly cross plasma membranes and go into cells? Can it? No, right? So what does that tell us? There is some sort of a receptor pathway. We will look at that, right? We will look at that, right? And if you all want to know further, 191 amino acids. Okay, right? Plasma concentrations, guys. Plasma concentrations of growth hormone, right? It's in the range of 0.4, right? 0.4 to 10.0, right? Micrograms per liter, right? 0.4 to 10.0 micrograms per liter. This one, guys, in males and females, it varies a little, but we don't need to know, right? We don't need to know, right? The other thing, guys, this plasma concentration. So first thing I want you all to know, males not equals to females. Huh? There can be slight variations. That's the first point, right? No need to know more than that, right? If it's needed, I will let you all know. The other thing, what you need to know, guys, this range reduces in old age, right? In old age. So how it goes is, guys, children have the most, right? Then you have young adults. Okay, and finally you have old individuals, right? Especially if they are somewhere around the age of 60 and above, right? They have the least amount of growth hormone. Okay, right. Then, guys, tell me this. Now you all can tell me. Growth hormone release, right? Stimulated by what? What hormone?
GHRH.
Excellent. GH, growth hormone releasing hormone, stimulated by growth hormone releasing hormone. What nuclei from the hypothalamus? Which nuclei secrete this?
Arcuate and
Arcuate and
ventromedial.
excellent. Arcuate and ventromedial nucleus, right? Arcuate and ventromedial nucleus. Inhibited by what, guys? Inhibited by what? Somatostatin. Somatostatin released from where in the hypothalamus?
Periventricular.
Excellent. Periventricular nucleus, right? Excellent. You all remember. Good. So we'll build up on this today. Huh? Right. Then, guys, a few more features about growth hormone I want you all to know. Growth hormone, guys, characteristically, right? First thing, pulsatile release, right? It's also a pulsatile hormone, pulsatile release, right? Pulsatile. Here, guys, we get one pulse every 3 to 4 hours. Every 3 to 4 hours, we get one pulse, right? Every 3 to 4 hours, right? The second thing I want you all to know, guys, there is a diurnal variation, right? Diurnal variation. What is this diurnal variation, guys? Variation in the day-night cycle. What I want you all to know, this is usually higher at night, guys. Usually higher at night. Especially, write this down, guys, during non-REM sleep. Right? You all know, guys, our sleep, right? Our sleep is mainly divided into non-REM and REM, right? Non-REM and REM. REM means what, guys? Rapid eye movement, right? Your REM sleep, right, is when you're usually seeing your dreams. Okay, your REM sleep, right? So growth hormone is high when you're not seeing dreams. Huh? Okay, right? In the non-REM periods. Okay, right. Here, guys, what I want you all to know, this diurnal variation, it looks something like this. Okay. Okay. Sorry about that. Yeah. Okay. So what I wrote has gone. I hope you all wrote those things, right? Something is wrong with my device. Anyway, we'll look at this diurnal variation, guys. It looks something like this, right? You all can draw a small graph, right? Okay. Usually nothing special, guys. I don't want you all to draw anything special here, right? Just put, okay, we will put from 8 a.m. We will put somewhere around here 12 p.m. and then again 8 p.m. and 12 a.m. in the night, and all the way to next day morning 8 a.m. So this is a 24-hour period from 8 a.m. to another 8 a.m. A 24-hour period, right? Right. What it looks like is, guys, something like this. What it looks like is something like this, right? There can be fluctuations, but there are pulses. And towards the night time, guys, towards the night time, this increases and then decreases again, right? This is what it looks like. Pulsatile in nature and higher at night, especially during sleep, especially during non-REM sleep. Except, guys, there is an exception here. There is an exception here. Except if at any time of the day you do exercise, you do strenuous exercise, right? If you do strenuous, let's say this fellow did some exercise at around 4 in the evening. So somewhere here, it will go up like that, guys. It will go up like that, right? This is an exception. If you do strenuous exercise, right? Strenuous exercise is a good stimulus for growth hormone, right? Okay. Right. Okay. During the daytime, guys, right? During the daytime, let's say someone who has not done any exercise, if you actually test their blood for growth hormone, right? About 50% of them, you will get null values. You can't even read the amount of growth hormone. Why? Pulsatile in nature. Pulsatile in nature, right? So you don't know when exactly it's being released, right? Right? Okay, up to this, all good up to this, right? Okay, now take a new page, guys. Take a new page, right? And let's look at this, right? Control of growth hormone release. Control of growth hormone release, right? How is this growth hormone released and in control, right? Let's look at this, right? Right, look at this, guys. You all can draw a very rough hypothalamus, right? No need anything serious, right? Something like what we drew yesterday, right? Okay, something like this, not a problem, right? And then draw a blood vessel underneath that. Okay. Right. Right. And then underneath that, draw a liver. Right? Liver. This is our liver. Huh? Okay. Right. In the hypothalamus, guys, you all can draw our 3 friends, right? Who are our 3 friends? First one, arcuate nucleus, right? If you all remember the structure, right? Arcuate nucleus. Then we had ventromedial nucleus, right? Okay, and finally, what did we have? Periventricular, right? Periventricular. These are the 3 nuclei we talked about yesterday, right? All good, right? Look at this. Let me do a drawing. Right. Look at this, guys. Right. What did we say? Arcuate nucleus. Both of them we drew hands, right? Remember? Yeah. Arcuate and the ventromedial nucleus, what do they produce? They both produce, let me move these lines. There we go. Right? They both produce, guys, growth hormone releasing hormone, right? Growth hormone releasing hormone, GHRH. And what happens? Growth hormone releasing hormone and can come and stimulate what is this cell? What is this cell, guys? What is this cell? Somatotrope, right? Somatotrope. This is an acidophilic cell, we said, right? How does it come and stimulate, guys? Nothing special. There is a receptor. There is a receptor. So this fellow can come and bind here, right? He can come and bind them, right? Okay, right. Then what does this somatotrope produce, guys? What does this somatotrope produce? It produces, it produces growth hormone. It produces growth hormone, right? What does the periventricular nucleus produce, guys? Periventricular nucleus, what does this fellow produce?
Somatostatin.
Somatostatin. And somatostatin, it can come, what can it do? It can bind here, give an inhibitory signal, right? Inhibitory signal, right? And if somatostatin comes and binds, what will happen? Growth hormone will reduce. Now everyone knows this. Now up to this point, all should be clear, right? Now we'll take a step further from here, right? What happens is, guys, growth hormone, firstly, growth hormone can do its own effects. We will see its own effects in the pathophysiology part, right? Here, what is another hormone that growth hormone helps produce is in this liver, guys. Growth hormone can come all the way here, and hepatocytes will have a receptor for growth hormone, right? Hepatocytes will have a receptor for growth hormone. This receptor is quite special, guys. This receptor is quite special. Why is it quite special? It has a very special intracellular domain, right? It has a very special intracellular domain. What it looks like is, guys, you all can draw it like two faces, right? Two faces, okay? Right, there is a dimerization and everything that is going on here. We don't need to talk about that, guys. I will tell you only what's important, right? Here, what happens is once growth hormone comes and binds to this growth hormone receptor, right? This growth hormone receptor, guys, in its intracellular domain, it has a special enzyme. These two phases we drew are special enzymes, right? These are called JAK. These are called JAK enzymes, guys. Okay, JAK enzyme. These are Janus kinase, right? Janus kinases, right? Janus kinases. JAK. Okay, JAK. Okay, right? What happens, guys? As soon as growth hormone comes and binds to its receptor, this Janus kinase enzyme, the JAK enzymes, they get activated and they start throwing phosphates, right? They start throwing phosphates at this other intracellular molecule, guys, right? At this other molecule called STAT, right? These fellows, they start throwing proteins at this. So what is happening? Not proteins, sorry, phosphates. They start throwing phosphates at this. So what is this process called, guys? Phosphorylation. This STAT molecule is going to get phosphorylated. Okay, STAT molecule gets phosphorylated. Why? Janus kinase starts throwing phosphates at this fellow, right? What is happening when STAT gets, guys, what? Okay, this STAT, what does it stand for? STAT stands for, right? STAT, you all can write it in a side. It's a very long name, right? Signal transducer, right? Activator of transcription, right? STAT, signal transducer, activator of transcription. Now forget the signal transducer part. This is an activator of transcription, right? What does that tell you? It's going to do some sort of protein synthesis activity. It's going to help with some sort of protein synthesis activity. Let's see what is happening. This STAT, guys, once it gets activated after getting phosphorylated, it will come into the nucleus, right? It will come into the nucleus of the hepatocytes, right? You all know the nucleus has a genetic material, right? The STAT molecule will come and start transcription of certain genes, right? Transcription will be happening. What happens when we transcribe, guys? What do we produce? We produce certain mRNA. Certain mRNA molecules are produced, right? mRNA molecules are produced. mRNA, what should happen, guys? What should happen to this mRNA? It should go into a ribosome, right? It should go into a ribosome where it will be what? Translated. It will be translated, right? Translation, right? So this mRNA, it will be brought here. Translation will happen. Eventually, they are going to produce a protein. They are going to produce a protein. Guys, draw this in both sides, guys. Right? I will tell you all the reason because we need it for our diagram. Right? Draw one mRNA translation there and another one here. Right? I will increase this a little bit longer. I will make my liver a little bit hypertrophied. Huh? No hypertrophy. Huh? I'm just saying, right? A little bit of a larger liver, right? Right. And this is also going to produce. What is this protein, guys? Look at this. This protein looks something like this, right? Right. It is a chain of amino acids. Don't worry, right? Look at this, right? This protein, guys. This is called IGF-1. IGF-1, insulin-like growth factor 1, right? Insulin-like growth factor 1. Okay, this is also given another name, guys. It is also called somatomedin. Somatomedin C, right? This is also called somatomedin type C, right? Somatomedin C. Insulin-like growth factor 1, IGF-1, right? IGF-1. What happens to IGF-1, guys, right? Okay, give me a second. IGF-1, guys, it is brought into blood, right? IGF-1 is brought into blood. I will draw it as a circle. I will just draw it as a ball, right? IGF-1 is brought into blood, right? Now, what do we have? Growth hormone is in the blood. IGF-1 also is in the blood. Okay, this is how the production part happens. How the production part happens. Now you all know, guys, any hormone, right? Any hormone, if it is in the blood, what should happen, right? There should be some negative regulation, right? Otherwise, what will happen? Hormones will keep increasing in the blood, right? So just like that, there is some negative feedback mechanisms that can happen. So let's say, for example, now growth hormone is a little bit high, right? I will draw a little bit more growth hormones, right? Growth hormone is a little bit high. And I will say IGF-1 is also a little bit high now, right? You all can draw in the same diagram, no problem, right? Okay, IGF-1 is also a little bit high, right? Now, guys, what I'm going to do, I will draw the negative feedbacks in a dotted line, right? First thing, guys, growth hormone. Growth hormone, one of the first things it can do, guys, it can negatively impact the somatotrope. It can have a negative action on the somatotrope, right? It can have a negative feedback on the somatotrope. So what will it come and tell? Okay, somatotrope, enough production of growth hormone. We have enough now. So stop for a while, right? A little bit of negative feedback there, right? Now, tell me this, guys. In the hypothalamus, out of these 3 nuclei, if the growth hormone wants to negatively regulate something, negatively regulate itself, what should it stimulate? What should it stimulate in the hypothalamus?
Reventricular.
Excellent. That is exactly what happens, guys. Growth hormone can come here, all the way here, right? All the way there, right? And give a positive, or should I put a positive sign here for this line or a negative sign here?
Positive.
Don't mix this up. It stimulates the periventricular nucleus. Why? To produce more somatostatin, right? When somatostatin comes, growth hormone will be reduced. Okay, right? Okay, clear? Right. What about IGF-1, guys? Now tell me this. If growth hormone was not there, if growth hormone was reduced or not there, can our body produce IGF-1? If growth hormone was not there? No, we need growth hormone to increase IGF-1. So if IGF-1 wants if IGF-1 increases in the blood, like we have drawn in this diagram now, and it wants to reduce itself, what should it do? It should reduce growth hormone, correct? It should reduce growth hormone. So exactly that. What does this fellow do? First thing, guys, right? He can have a direct action on this somatotrope. What is that action? An inhibitory action. He can have an inhibitory action on the somatotrope, right? Apart from that, again, what can he also do? He also can go all the way here and have a stimulatory action on the periventricular nucleus, right? Another stimulatory action on the periventricular nucleus, right? Did everyone understand this? Right? Okay. Right? Okay. Now look at this, guys. Now we'll look at, so this is the basic feedback mechanism. Once growth hormone releasing hormone and somatostatin are acting, right? So y'all can, if y'all have highlighters, right? This pathway, y'all can put it in green, right? It is a stimulatory pathway. Then this one, y'all can put it in a red, right? Somatostatin, inhibitory pathway, right? Either way, look at this. Now we learn how growth hormone was produced and how it was released. And once it comes to the blood, how it is negatively by a feedback, how it is controlled. But what caused these nuclei in the first place to produce the growth hormone, right? That's what we are looking at now. What stimuli came here, right? So you all can write here on this side, guys, we'll look at the stimulatory factors. In this side, we'll look at inhibitory factors, right? Here, put the topic factors stimulating, right? Growth hormone release. Factors stimulating growth hormone release, right? Look at this, guys. First thing, we'll look at some factors from our blood itself, from our serum, right? From our serum, right? First one, guys, reduced glucose, reduced blood glucose. What is this? Hypoglycemia, hypoglycemia, right? Reduced blood glucose can stimulate growth hormone to increase, right? Reduced blood glucose, right? Then an increase in amino acids in the blood, right? Increase in amino acids in the blood, right? We will see how this happens. Don't worry, right? Increase in amino acids in the blood. Then put, guys, a reduction of fatty acids, reduction of fatty acids in the blood. Okay. Don't worry, yeah. These ones you don't need to memorize. Once we look at the mechanism, you will fully understand what's going on, right? For now, just write them down. And then there is another one, guys, a hormone called ghrelin, right? Ghrelin, right? Okay, this is coming from our digestive tract, guys, right? It has a minimal function in the digestive tract where it helps with some sort of, it can help with hunger, right? It can help with gastric motility a little bit, right? It can help with the production of some gastric enzymes. Apart from that, here, with regards to growth hormone, ghrelin plays a little bit of a big role, right? It can stimulate growth hormone to increase, right? Now tell me this, guys. Here, ghrelin, is it coming only from the hypothalamus? From the hypothalamus, ghrelin needs to come, or can it come from somewhere else? Where can it come from?
GI?
Yeah, from the GI. How is it coming all the way to the pituitary? How? So yesterday, how, guys, tell me this, these hypothalamic hormones, right? How is it brought to the anterior pituitary? Via, via the portal vein. But how was this? Now look at this. If we, you all don't need to draw it, huh? just for you all to get this clear, right? The portal vein, guys, how did it form? There was a superior hypophyseal artery which brought in the blood, right? And then it broke down into capillaries, and then the portal vein, and then another capillary system, and then it entered the venous circulation, right? Okay. So look at this. So blood has to come this way, and this blood is coming from where? From our systemic circulation, right? So hormones and molecules, like for example, this glucose, amino acids, fatty acids, right? Ghrelin, these things also come along with this blood, right? That's how they are coming here, right? Now ghrelin, guys, they have found out actually in the hypothalamus also there are some locations that can secrete ghrelin, right? Okay, so hypothalamic ghrelin is also there, but this our GI system ghrelin also can come here. Okay, don't forget that. Okay, just for you all to get that point clear, right? Okay, so those are the main serum things. Then guys, put another small thing, others, right? We put it as others. Others, what are some of these other stimuli? One thing we already talked about, exercise, right? Then guys, alpha adrenergic stimulation, so even if you give alpha adrenergic agonist drugs, you have to know that this also can stimulate growth hormone, right? Alpha adrenergic stimulation. Then write down, guys, non-REM sleep, important, right? Non-REM sleep. Okay, and then guys, just write these also down because they have found them to be true: sepsis and trauma, right? Sepsis and trauma, right? Okay, look at this, guys. All of these factors, you all can put a nice bag around it, right? All of these factors, in order for them to increase growth hormone, right? In order for them to increase growth hormone, what should they do to your hypothalamic nuclei? Look at this. For your arcuate and your ventromedial, guys, what should it have? What should they do? They should come and stimulate. They should come and stimulate these nuclei. Okay. What about our periventricular? There should be a inhibitory stimulus to the periventricular, right? Okay, now look at this, guys. We'll look at the other side, factors that inhibit growth hormone release, right? Factors that inhibit growth hormone release. So again, we will look at some serum factors, right? What are these, right? Opposite of some of the things that we talked about in the stimulating side, right? One thing, increased glucose, right? This one, guys, very important because for our diagnostic test, we are going to give the person some glucose and look at his growth hormone, right? Okay, so that is very important. Increased glucose can cause a reduction in growth hormone, right? Okay, then another one. What about amino acids? Reduced amino acids, right? Fatty acids, increased fatty acids. Okay, then guys, here there is another small role played by cortisol as well. Cortisol, they say, can have an inhibitory effect on growth hormone. Okay, right. Then we'll look at the others on this side. Others. Now, on the stimulating side, what did we have? Exercise. On the inhibitory side, opposed to that, what should you have? What do you all think? No exercise? Obesity, guys. Obesity. Then aging. We said with age also, growth hormone can really reduce, guys. Right? Aging. Right? Aging. Then another one is, guys, REM sleep. In the rapid eye movement phase, basically when you're dreaming, right, your growth hormones are less, right? Right? And just like on the stimulatory side, we talked about alpha adrenergic stimulation. On this side, right, for the inhibitory side, guys, it is beta adrenergic stimulation, right? Okay, beta adrenergic stimulation. Now, these effects, right? If they want to reduce growth hormone secretion, right? What should they do to the various hypothalamic nuclei? Tell me. First, tell me what should they do to the periventricular nucleus?
Stimulate.
Excellent. They should stimulate this. What about the arcuate and the ventromedial? What should they do? Huh? Arcuate and ventromedial. Yeah, they should be inhibited, guys. Right? Guys, my diagram is a little bit messy. Draw it as clearly as possible. Huh? The arcuate and the ventromedial should be inhibited. Okay. Right? Okay. Is this clear? This is how, so look at this, guys, a very complex mechanism to control. Like we have from our growth hormone and IGF itself, we have negative feedback pathways. Apart from that, right, these various factors, by stimulating or inhibiting the various nuclei, they also help to regulate, right? So this control of growth hormone is very complex, right? Okay. Now these factors that I told you all, guys, these are the main ones you all need to know for MBBS, right? But if you look at some textbooks, right? I think I have put a picture. I think I cannot remember from which textbook I took it. Oh, I think this is from, might be Kumar and Clark. I'm not sure. So look at the amount, right? No need to know all of these. Huh? No need to know all of these. Know the main things. The main things are what we talked about. Okay. These are the main things, right? Okay. One more important point here, guys. Look at this. Now what is happening? Growth hormone and IGF-1, whenever they are in blood, guys. Growth hormone and IGF-1, whenever they are in blood, they are hormones, now, guys. They are hormones, right? Like other hormones, right? Most of them, about 50%, right, is protein bound, right? They are going to bind to plasma proteins. Protein bound. Okay, protein bound, right? That's how they travel in the blood, right? And wherever they are required, they will be made free, right? Wherever the tissue that they are required, right? What I want you all to know, guys, IGF-1, insulin-like growth factor 1, binds to plasma protein with a very, very, very high affinity, compared to growth hormone, right? Growth hormone binds to plasma proteins very mildly. Okay, IGF-1 very strongly binds to plasma proteins, right? So if I'm asking you, right, now you all know as these hormones are circulating in the body, right, some of them will be released to target sites, right, and then some of them will be eliminated by the liver itself. This is how hormones usually work, no, guys, right? Tell me this, if IGF-1 is very, very, very strongly bound, right? Tell me this, which one, growth hormone or IGF-1 remains in the blood for a longer duration of time? Which one?
IGF-1.
Excellent. IGF-1, guys, its elimination rate, because of this factor, right? Elimination rate is low. So it remains in the blood, right? It remains in the blood for a much longer time. Actually, guys, if you look at the half-life, right? Growth hormone, guys, it has a half-life about 20 minutes, right? About 20 minutes. We said every 3 to 4 hours, we get a growth hormone pulse, right? From that pulse, within about 20 minutes, that growth hormone is gone. It's eliminated, right? IGF-1, guess how much? It can have 20 to 24 hours. Okay, look at the difference, right? Minutes, 20 minutes versus 20 hours, right? Okay, right? So we have still not come to the diagnosis, but just based on this fact, if we want to diagnose a disease where there is a growth hormone abnormality, which one is best? Which one is best?
IGF-1.
IGF-1, right? We'll come to that in the diagnostics part, right? Okay. But this is what you should know. Half-life is very strong, very long, right? Right. Everyone clear up to this point? All good, right? Now we are going to go into the heavy machinery, yeah? Right? Now I want you all to, if you all have a glass of water nearby, drink it, right? We are going to dive in. Things are going to get a little bit hot and spicy, right? Look at this, guys. We'll come here. Take a new page, right? We are going to look at how this growth hormone and the somatomedin or insulin-like growth factor, how do they work together, right? How do they work together? So this is, we are looking at the physiology behind this, right? First thing I want you all to know, guys, this growth hormone and IGF-1, right? These findings are not very ancient. These are relatively new, these mechanisms. So what, firstly, what they thought was, right? Maybe around 50 to 100 years ago, what they thought was, okay, growth hormone comes into the blood, it goes to all the tissue, does it work, right? That's what they thought. Then later they found IGF-1 and they were like, oh, okay, not growth hormone. Growth hormone comes to the liver, produces IGF-1, and IGF-1 is the fellow who is doing the job, right? That's what they thought then. Now the current belief, guys, what we know up to now with present evidence is that both of them work hand in hand, right? Growth hormone helps IGF, IGF in return helps growth hormone, right? We'll see how that is happening, right? So look at this. Take a new page, take a new full page, right? Draw two blood vessels like this, guys, right? Two blood vessels, one at the very top, right? So you all can write the topic as mechanism of action, mechanism of action, how these hormones are working, right? One at the very top and one at the very bottom. Right? Now this diagram is the only reason I couldn't use the whiteboard today, because it is undrawable on the whiteboard, right? So take a new page. This diagram gets a little complex, okay? But I'll make sure you all understand. If at any point you all don't understand something, let me know. There are some mechanisms that we need to know, some things that are still under research, which I will let you all know, right? Just draw two blood vessels like that, guys. Okay. Right? In the top blood vessel, guys, we'll start with our growth hormone, right? Now just know these functions, they happen together, right? We will see. But we'll start off with the growth hormone. We have to start off somewhere, right? We'll start off with growth hormone. Let's say due to all the stimuli coming from the hypothalamus or externally, the patient has done exercise or whatever, right? Due to some reason, growth hormone is high. Growth hormone is high. Let's see what is happening. Okay. Right? Look at this, guys. First of all, one of the very first sites of action for growth hormone, guys. Now, what is the major role of growth hormone? Our physical growth and development, right? Growth hormone, we said, even if you consider precocious puberty, it doesn't even play a role, right? Mainly physical growth and development, basically increase of bone length, right? And visceral tissue, right? Visceral tissue sizes, right? That's the major function of growth hormone. So one of the major places where growth hormone starts its action, guys, is our muscle. So I will draw a muscle like this. You all can draw somewhere here, right? A muscle tissue, right? Muscle tissue. This is a muscle tissue, right? Muscle tissue. What happens is, guys, right? These muscle tissues, what do they have? Obviously, we have the receptors for growth hormone, right? Receptors for growth hormone. So what happens? Growth hormone comes and binds here, right? Okay, various intracellular signaling pathways. We are not going to talk about those, right? What is happening? Eventually, signals are sent, right? Our JAK-STAT pathway is also one of them, but there are others as well, guys. There are others as well. So no need to talk about them. JAK-STAT is also one of them, right? It's going to come and stimulate the nucleus, right? Nucleus, what is it going to do? It is going to start various protein productions, right? Various protein synthesis things are going to happen. One such protein that is produced, guys, is a special transporter. It is going to produce a special transporter on this muscle, right? A special transporter on this muscle, right? What is this transporter, guys, right? This is an insulin sensitive amino acid transporter, right? Insulin sensitive amino acid transporter, right? Okay, so what is happening? Whatever amino acids that are in the blood, right? Whatever amino acids that are in the blood, right, will be nicely taken up, will be nicely coming into the muscle. There is an influx of amino acids, right? These are amino acids, amino acids from the blood into this muscle tissue, right? Right? Amino acids coming into the muscle tissue. Now tell me this, guys. Inside this muscle tissue, if there are a lot of amino acids coming in, what are amino acids used for? What are amino acids used for?
Protein.
Protein synthesis, right? Protein synthesis. So what is going to happen within this muscle, guys? Protein synthesis increases, right? Protein synthesis increases. In muscular tissue, if protein synthesis increases, what happens in muscle tissue?
Hypertrophy.
Hypertrophy. Muscle is going to get bigger. Why? More and more proteins. This is why all the bodybuilders take protein supplements, right? Because they want more protein. So what is going to happen, guys? This muscle is going to hypertrophy, right? You all can draw a nice hypertrophied muscle like that, right? Something like that, right? Hypertrophy. Okay, hypertrophy of the muscle, right? Hypertrophy of the muscle. My muscle looks a little abnormal. You all can draw a nice one, huh? Draw a nice one, right? Okay. Clear? Right. Now, let me make this growth hormone green was better for us. There we go. Right. Okay. I will draw a little bit more growth hormone here, right? Because I need this vessel to show, right? Somewhere here also. These are all growth hormone. Huh? This green is growth hormone, right? Right. Now look at this, guys. The next thing, right? So this is one of the first thing. Muscle hypertrophy. Muscle hypertrophy. We'll see what is happening. The next thing, guys, growth hormone also acts on our adipose tissue. You all can draw some adipose tissue here, right? Okay. This is adipose tissue. Right? These adipocytes, guys, these are our adipocytes. Adipocytes also have the receptors, right? They also have the receptors for growth hormone. So what can happen? Growth hormone will come all the way here, right? And bind here, right? Now, in our adipocytes, guys, sorry, what do we have? We have triacyl glycerols. You all know, guys, how the structure is, right? We have glycerol molecules, right? Glycerol molecules like this, and they are joined by three what? Fatty acids. Three fatty acids like this, right? Something like this. This is the structure now, right? So these adipose tissues are full of this, right? They are full of this. They are full of this triacyl glycerols, right? What happens, guys? When growth hormone comes and binds to these receptors, growth hormone receptors on adipocytes, there are again intracellular signaling pathways, which we do not need to talk about. These pathways are going to start production and activation of a specific type of hormone. Draw this like a bird, guys. Okay? Like a bird. This is, guys, this is called hormone sensitive lipase. Hormone sensitive lipase, right? Hormone sensitive lipase. Hormone sensitive lipase. What does hormone sensitive lipase do, guys? It comes and cuts this. It comes and cuts this connection, right? Between the glycerol and fatty acids, right? What is this called? This process is called lipolysis, right? Lipolysis, right? Lipolysis. Okay? Lipolysis. Now look at this. Right? Lipolysis. Now when lipolysis happens, guys, what is happening? A lot of fatty acids and glycerols, they are now separated. So they will be coming into the blood, right? They will be coming into the blood. Now look at this, guys. What happens? These separated ones, they come into the blood. So we have glycerol molecules increasing in the blood, right? Glycerol molecules in the blood is going to increase. At the same time, fatty acid chains, right? Free fatty acids, we call these free fatty acids. Free fatty acids increase, right? Glycerols also increase. Glycerol also increase. Okay, glycerols also increase. Right? Right? Now look at this, guys. Just we still haven't done anything, right? Take a look, just go a little bit your previous page. Take a look at the stimuli that influenced or enhanced growth hormone release. One of the things we said was increased amino acids, right? Increased amino acids. Now, can you see the problem being solved? Whatever amino acids were increased are taken into muscle cells, right? Problem solved, right? Look at the other one, reduced fatty acids. Reduced fatty acids. Now what? Problem solved. Fatty acids increased in blood. Okay. Still we are not done. Nah? We have to come into the big picture. But for now, just note these down. Nah? Just keep these in your mind. Right? We'll come. Right? Little by little. Right. Now, let's look at the next part. This free fatty acids, guys. We'll look at what happens to these free fatty acids and these glycerols. Right? These free fatty acids and glycerols, guys. Let me draw it a little bit closer to this. Right, there is not enough space. Right. Okay. Now I'm going to draw a liver, guys. You all can draw a liver, right? Draw a little bit of a larger liver. Right. Don't use all the space. We need more space towards the right-hand corner. Just draw it in the middle. A liver, right? This is a liver. Right. Okay. Right, look at this, guys. These fatty acids and glycerols, what is going to happen to them? Let's first look at the fatty acids. The fatty acids, guys, it will go through the circulation, right? And once it reaches the liver, it will enter the liver, right? Same for the glycerols. Both of these things will enter, right? Glycerols and fatty acids will enter the liver. Let's see what is happening. Fatty acids, guys. Fatty acids, when it comes to the liver, right? What is the pathway to break down fatty acids? Have you all heard? Beta oxidation, right? Right. Beta oxidation is going to happen, right? Beta oxidation. Beta oxidation happens, guys. What is it going to produce? Acetyl-CoA, right? Now these are biochemistry, right? Biochemistry. Recall. Supposed to be recall, but I mean, it's okay, right? The acetyl-CoA, what is it going to do, guys? So from here, right? It is going to go through this TCA, right? And in the case of fatty acids, right, we have the electron transport chain to produce eventually ATP, right? To produce eventually ATP, right? To produce ATP. What about the glycerol, guys? What about the glycerol? Look at this glycerol. Glycerol, what happens, guys? Glycerol can be converted to something called glyceraldehyde 3-phosphate. Have you heard this? Glyceraldehyde 3-phosphate. Right? Glyceraldehyde 3-phosphate. And that is converted to what? What is that converted to? Glyceraldehyde 3-phosphate. This is the opposite of glycolysis. We are producing glucose, right? We are producing glucose, right? Glucose. And that glucose can then be utilized to produce ATP. Now tell this, guys. Glycerol, when it was broken down in this way, what is this process called? We are using non-carbohydrate sources. Glycerol is not a carbohydrate. Excellent, right? We are using a glycerol is not a carbohydrate. So we are using a non-carbohydrate source here to produce glucose. What do we call this? Gluconeogenesis, right? Gluconeogenesis, right? So what does this tell you, right? Our growth hormone, it is going to stimulate gluconeogenesis, right? Gluconeogenesis, right? For now, guys, just tell me this you all can draw this like this. This gluconeogenesis, it does what? It spares carbohydrates, spares carbs, right? It spares our carbohydrates. Also, it spares what? Proteins, because we are using glycerol now. So proteins also spared, right? Just keep it written down. We'll see what is happening, right? We'll see what is happening. Okay. Right? Did everyone understand up to this? Right? Look at this, guys. Here, we produced acetyl-CoA, right? We produced acetyl-CoA. Acetyl-CoA, guys, right? It will be used up, right, to produce the energy, but some of it, right, especially if there is excess, it will be converted to something called, guys, have you all heard acetoacetate, right? And that comes into the blood in the form of what? What do we call these, guys? Anyone?
Bodies.
Ketone bodies. Excellent. Ketone bodies, right? Ketone bodies. So what is happening due to growth hormone, guys? Ketone bodies can increase a little in the blood, right? Right? Still, we are talking normal physiology. Huh? These can happen. This is normal physiology, under the normal physiological ranges of growth hormone. We have not come to the diseases yet. This is normal physiology, right? Okay, right? Just for you all to recall, guys, if the ketone bodies are pathologically high due to some disease condition, which we will talk about, right? If it is pathologically high, what is happening? What is the condition we get?
Ketoacidosis.
Yeah, we get metabolic acidosis, right? We call it ketoacidosis, right? It's a form of metabolic acidosis, right? Good. That's pathology, yeah? Right. Now look here, right? Ketone bodies increased a little bit. We'll take this free fatty acids a little bit here as well, guys, because we need these fellows here a little bit as well, right? The same free fatty acids, huh? I'm taking it a little bit here in the vessel, right? Free fatty acids, guys. Now here is I know this is where some students will message me, asking certain things, right? Okay. Look at this. Free fatty acids, guys, when it increases, right, there is an effect that it has specifically on insulin receptors in our body, right? What it does is, guys, there is reduced insulin receptor sensitivity, right? Reduced when the free fatty acids are high, right? Insulin receptor sensitivity drops a little, right? The exact mechanisms, guys, these are very, very complex, right? We are not going to talk about these, right? Exact mechanisms of this, most of it is still under research, right? There is something called a kappa B pathway, right? Not needed. If anyone is interested, right, I can point you to some sources, but I suggest not to even read, right? Very complex mechanisms. How this exactly happens, we don't know, right? But just try to remember, when free fatty acid, when these acids are a little bit high, insulin receptor sensitivity reduces a little bit, right? So if insulin receptor sensitivity reduces, what is happening to the overall functionality of insulin? What happens? Decreases, right? Functionality, you all can write this down. Functionality of insulin reduces. Right? So what do we mean by this functionality, guys? We are mainly talking about a few things. Look at this. What do we mean by this? One thing, cellular glucose uptake. Now you all will learn insulin physiology. Sasanga will be teaching you all how it works, right? What do you all know? It's okay, we haven't still taught you. What does insulin do to, in normal conditions, if insulin is normal, what happens to cellular glucose uptake? Increases or decreases? Yes, normally it increases. Now, since the function of insulin is dropping, what is going to happen? Cellular glucose uptake is going to reduce. Okay, right? Cellular glucose uptake is going to reduce. Another one, guys. What do you all think? When insulin is there, what happens to gluconeogenesis pathway? Don't worry, we haven't taught you all. Huh? These will be taught in insulin physiology, right? Don't worry about it. If you all know, just tell me. When insulin is there in our body, what happens? Yeah, gluconeogenesis pathways are going to be reduced, right? Usually, insulin inhibits inhibition of gluconeogenesis. But that is usually. What happens when insulin is low? Like now, what is happening? This inhibition is reduced, right? Reduced inhibition of gluconeogenesis. What does that tell you? What does that mean in simple terms? What is happening to gluconeogenesis?
Increasing.
Increasing. In simple terms, right? Gluconeogenesis is stimulated. Stimulated. Okay, stimulated. Right? Okay. Did everyone understand? Let me see some faces. I'm scared about this section today. Right? Okay. Right. Okay. Right? Don't worry. Once we get the entire picture, right, it will come. Don't worry about it too much. Look at this. Now look at this, guys. Cellular glucose uptake was reduced, right? Cellular glucose uptake was reduced. Why? Insulin receptor sensitivity dropped, insulin function dropped. When cellular glucose uptake reduces, where will glucose remain?
In the blood.
In the blood. In the blood. Now look at this. Because of this, blood glucose elevates. Blood glucose elevates, right? Blood glucose elevates, right? Okay. Now, can you all see another problem solved? Do you all remember factors that stimulated the growth hormone release? One of the ones we said was low glucose. Low glucose. Now see, blood glucose increase, right? Okay. Don't worry. Still not done. Still not done. We have a little bit more to go. Look at this. So this is a very major point, guys, right? Highlight this, right? You all can highlight or circle or do whatever, right? Put a star. These are one of the most important points in this path, right? Increased blood glucose, right? Okay. Now, when blood glucose is high, right? Okay. Right? Right? Look at this. When blood glucose is high, right? What do you all think happens to this organ? What is this organ? This is our pancreas. Pancreas. Whenever blood glucose is high, what is going to happen with regards to the pancreas? There is going to be a stimulation of the beta cells, right? Beta cells are going to get stimulated. Stimulation of beta cells. Stimulation of beta cells. And what are the beta cells going to do? What are the beta cells going to do? It's going to secrete insulin. Now what is happening? Insulin level in blood increases. Insulin increases, right? In the blood. Insulin in the blood increases, right? Did everyone understand up to this? Right? Now look at this, guys. When this insulin increases here, just from the structures we drew, can you all tell me another arrow or another line I should draw from connecting something to something? From insulin, what should I draw to? Where should I draw to? A line. Can you all? Sorry?
Insulin sensitive.
Excellent. Yes, right. This one, right? Insulin sensitive amino acid transporter. You all can draw a line all the way here. This is going to help this function, right? Okay. Right? Insulin sensitive amino acid transporter. Did everyone understand up to this? Right? Still not done. Still not done. Right? Take this a little bit smaller. Little bit. I just need a little bit of corner space. Right. Look at this. Okay. Right. So these guys, these are some of the metabolic reactions happening with the help of growth hormone. We are still not done. These are some of the metabolic things with regards to metabolism in our body. right? Now we'll look at specifically we'll be more specific to the bones, right? To the bones. What happens with regards to growth hormone with the bones, huh? Bones. I'm going to again draw some of those growth hormone, right? Growth hormone is elevated, right? Growth hormone is elevated here, right? Growth hormone is elevated. Look at this. What happens is, guys, right? Growth hormone comes, right? And it also has receptors in bone tissue, right? I'll draw a bone like this, right? There are some receptors. Now, in these bones, guys, especially in long bones, right? Even the other bones, not just long bones. We will talk about the special things later in the diseases. There is something called an epiphyseal plate, right? Epiphyseal plate. There is something called an epiphyseal plate, right? Here, guys, there is a cell type called chondrocytes. Chondrocytes, right? These are called chondrocytes. These blue dots that I have drawn are chondrocytes. Chondrocytes, right? When growth hormone comes, what happens, guys? There is going to be one of the first things that happened is chondrocyte hyperproliferation. Chondrocyte hyperproliferation. Chondrocyte hyperproliferation. How does this happen? Let's look at this step by step, guys. Right? I'm going to draw a small bone like that. Right? Now, look at this. Now I'm going to say first, okay, let me do it like this. I'll just draw one layer, right? One layer of chondrocytes, just to show that it's hyperproliferating, right? The second one, right? Then I will draw the next one a little bit more, right? Now it's hyperproliferating, right? What I want you all to know, guys, as chondrocytes hyperproliferate, right? Give me a second. As chondrocytes hyperproliferate, guys, the older layers of chondrocytes, that means the ones at the very bottom, right? The older layers, they start calcifying. The ones that I'm drawing in red now are those old chondrocytes that have calcified. They have calcified, right? The old layers start calcifying, right? And new layers start growing upwards, new layers of chondrocytes, right? They start hyperproliferating upward. So what is going to happen, guys, right? This thing, right here, I will draw one layer, right, like that. And then, guys, just give me a second. Don't draw. Y'all can draw this now. Just stop a little because I need y'all to draw the exact thing I'm drawing, right? It's going to appear something like this, guys. Right? What I want you all to make sure, guys, when you all are drawing is this, right? This layer, keep it in one line, right? This chondrocyte, the old chondrocyte layer, keep it in one line when you're drawing. And then, right, you all can draw the bone at the same length, right? Like that. What do you see, guys? The bone has been elongated as we go, right? Yeah, keep it in one line, the chondrocyte layer. Right, like that. Right? Okay. So what is happening? This is called what, guys? This calcification portion here. This portion here that is getting calcified. This is, guys, this is called endochondral ossification. Ossification, right? This is how the bone length increases, right? Chondrocyte hyperproliferation, right? Followed by calcification, right? Okay. Okay. Clear. Now, if you consider long bones, right? Usually we have epiphyseal plates on either end, right? On both ends. So what is happening to the other end? Other end also same thing happening, guys, little by little, right? It is going to keep elongating because that end also has a epiphyseal growth plate, right? You all can draw it later, right? Just keep it in the same line like that and draw the elongated portion, right? Okay. So the epiphyseal plate, you all can draw it, right? Okay. All right. Clear. Right. Now, is it clear up to this? Right. Another thing. So this is what happens when growth hormone comes and binds, right? One of the first things. Another thing that happens, guys, when growth hormone comes and binds, you can put it in this diagram itself. We can show, right? There is going to be increased protein synthesis. Right? When there is increased protein synthesis, guys, mainly we are going to produce here collagen. In bones. What is the type of collagen? In bones?
1.
Type 1, right? Bone, right? 1, right? Bone has type 1 collagen. Collagen type 1. Type 1 collagen is also going to increase, guys, especially in this shaft, right? In the shaft, you all can show an increase in collagen, right? Right, as you go, right? Something like this. Okay, increase in collagen. Okay, right? Okay. Then, so that is the second thing that happens in bone. So we looked at 2 things now, right? The third thing, guys, look at this. We have a third thing that is going to happen here, right? The third thing that is going to happen here, right, is this. Look at this. When, number 3, right? When growth hormone comes, guys, it is going to increase osteoclast and osteoblast activity. Both will be increased, right? Osteoclast activity, osteoblast activity, both will be increased. What I want you all to know, guys, first thing, when osteoclast and osteoblast, what does osteoclast do? What do they do?
Breakdown.
Breakdown, bone resorption, right? From the bone, taking out the mineral, it's demineralization. Osteoblast, what do? They form new bone, right? New bone formation, right? Now, when due to some sort of metabolic condition or whatever pathology, right? You all must have learned some diseases. If osteoblast and osteoclast activity increases, guys, what happens to some? Have you all heard a concept called bone turnover, right? There is a concept called bone turnover. What does it mean? Formation and destruction of bone. This rate of bone turnover increases, guys. Rate of bone turnover increases. Just keep this written down now. We will see. So under normal physiologic conditions, when this rate of bone turnover increases a little, not a big problem. But the pathology comes when growth hormone is very high, right? That's when the problem will come, right? Then another thing, guys, I want you all to know, right? Here, what they have found out is, right? Now, if you read your textbooks, you will see this. They have explained it, right? The osteoblast activity, the increase in osteoblast activity is much, much higher than the increase in osteoclast activity. Okay? Osteoblast activity is much, much higher than increase in osteoclast. What should happen to the bone? Should it be destroyed more or should it be formed more? What is happening? Yeah, more formation. What does this tell you, guys? Now look at this. If I draw a bone, right? Let's say this side is osteoblast activity. So it's forming, right? And on the other side, this side, Let's say it's osteoclast activity. So there is bone resorption. It's losing the substances into the blood, right? Into the blood. You all can draw something like this, right? This is a blood vessel, right? And here also blood vessel. This guy is taking all the substances from the blood, right? Now, if osteoblast activity is higher than osteoclast, can you all tell me this overall? What will happen to the bone? In one word, can you tell me, or two words? Huh?
And development.
Sorry,
Growth. And
guys, can you all hear each other, or is it something wrong? I think something is wrong with me. Give me a second. Okay, can you all talk now? Okay, what did you say? Hello, guys, can you all hear me? Okay, look at
the
okay, I can hear you. Yeah, go on.
length and the width will increase. Like
Yeah, more than okay. Look at this, guys. Now look at this. We'll look at these two processes, right? From this osteoclastic and blastic activity, right? When the blast activity is especially higher, right? We have a bone thickness increase. Bone thickness increase majorly, right? Main thing. Here, guys, when the chondrocytes hyperproliferated and endochondral ossification was larger, what do we have? Bone length. Yes, bone length increase mainly, right? Bone length increase mainly. Okay. Now, here's the important thing I want you all to know. After puberty, guys, this epiphyseal plate here, it closes. The epiphyseal plate closes, right? Okay. So this elongation of bone via chondrocyte hyperproliferation can occur only until epiphyseal plate closure, right? After that, this elongation does not happen. This is why we do not grow tall. This is why we become asymptote, right? This is why we don't grow tall after the after our puberty stops, right? But this activity, guys, this osteoblast class activity, this can happen even after epiphyseal plate closure, right? Depending on the conditions, right? Can occur even after epiphyseal plate closure. Okay, did everyone understand this? Right? Okay. Overall, guys, under normal physiologic levels, right? Overall, what is happening? Increased bone size. Now, when we say size, it can be length or it can be thickness, both. Huh? There is increased bone mass, right? And there is increased bone turnover. Don't forget this as well, right? But these are happening, guys, under physiology. We are still in physiology. Huh? Don't think of them as diseases here. Okay, still physiology. Did everyone understand up to this point? All good, all clear, right? Right? Little bit more in this diagram to draw, right? Still not done, right? Look at it. So now we talk about growth hormone, guys. Now, what works hand in hand with growth hormone? Who helps growth hormone? And what does growth hormone help? Right? Who?
IGF-1.
Yeah, IGF-1, right? Insulin-like growth factor 1. Insulin-like growth factor 1. So we'll draw insulin-like growth factor 1 in the bottom vessel, right? This is why I drew two vessels, just to get them a little bit separate, right? Okay. The first points I want you all to know, guys. The first few points I want you all to know. Very easy, nothing much. Take a color, take one color and draw one arrow from IGF-1 directly into this protein synthesis. IGF-1 stimulates protein synthesis in muscle tissue, right? Okay. Okay. So it just helps growth hormone. It helps the growth hormone to do its job there, right? Second thing, IGF-1 will help all these bony changes to happen. Bone size increase, bone mass increase, bone turnover increase. All of these are also helped by IGF-1, right? Okay, these two direct. right? Nothing much to talk about there, right? Then we have some special functions. Look at this, guys. Now, IGF-1. Now, usually, guys, if I give you a time, right? If I give you all a timer, I tell you start the stopwatch now. Right now, while starting the stopwatch, the person is having a growth hormone pulse. Growth hormone pulse, right? Right now, right? Brand new blood. He has brand new blood. This just for you all to imagine. No need to write down. Just for you all to imagine. Let's say person has received brand new blood. There are no hormones in his blood. Zero hormones in his blood, right? Hypothetical scenario. And I start the stopwatch and I say, okay, right now, growth hormone pulse is happening, right? Will the IGF also be immediately released, or will it take a little bit more time for IGF to be released?
Take time.
Yeah, it will take a little bit of, there is a little bit of a time difference, guys. Now, under physiologic conditions, this time defect is negligible. Why? IGF remains for 20 hours, right? IGF remains for 20 hours. So the time defect is negligible. But for you to get the understanding, what happens, guys, here, IGF, right? You all can take another color pen. IGF has a very important function right here. IGF, guys, has an anti-lipolytic activity. Lipolytic activity. Now look at this. Growth hormone, it helps lipolysis, right? IGF, once it is there, IGF has a little bit of an anti-lipolytic activity. Why is this important? Why is this important? Look at this diagram. The answer is in this diagram. Why is this important? To balance out what? What is IGF trying to help with?
Gluconeogenesis.
More than that, guys, this one, ketone body formation. We do not want an excess of ketone bodies, right? We do not want a lot of ketone bodies forming. Okay, we do not want a lot of ketone bodies forming, right? So this is why IGF has this, it helps to balance it out, right? Growth hormone comes, it helps lipolysis. IGF comes, it has a little bit of an, that makes sure that ketone bodies don't exceed the normal thresholds, right? And then cause metabolic acidosis. Okay, that is what is helping this, right? Then, guys, the other very important, the last function for this diagram, right? This is one of the most important. Look at this. IGF-1, right? What is this? What does it stand for? Insulin-like growth factor, right? Just from the name, what sort of functions do you think this fellow has? He has insulin-like activity. Insulin-like activity. Now, again, what is this? Growth hormone, what did it have? It had the reduction in the function of insulin, right? It had an anti-insulin activity, growth hormone. IGF-1 has the opposite, insulin-like activity. What is this going to do, guys? It is going to reverse some of those processes that growth hormone did. What are these processes? One of them, this gluconeogenesis is going to be inhibited, right? Okay. If gluconeogenesis is going to be inhibited, now what is going to happen? Carbohydrates are going to be used up, right? Now look at this. We spared the carbs. These carbs can now be used up. Right? These carbs can now be used up. Okay. Then another thing, right? What about the cellular uptake of glucose? Cellular uptake of glucose was reduced by the growth hormone. What does this fellow come and do? Increases cellular uptake of glucose, right? Increases cellular uptake of glucose, right? Okay. Now, right? Look at this overall picture, guys. Look at this overall picture, right? I will use a small anecdote to help you all keep this in your mind, right? Look at this. What is insulin? What is growth hormone and insulin-like growth factor doing here, right? First of all, guys, look at this. This is a very interesting mechanism. Instead of growth hormone just coming and telling, okay, muscles and bones grow, right? Instead of just giving a signal like that, what is this doing? Growth hormone first comes, right? And it makes a nice blood glucose store. It makes a nice blood glucose store in the blood, right? It increases glucose in the blood. Then what happens? Then IGF comes. IGF takes all this glucose from the blood and gives it to the tissues, right? Gives it to the tissues. Why is this important, right? Why is this important? Look at this, guys. Imagine you're a businessman, right? You're a businessman. You're selling these, let's say, okay, these are diary, not a diary. Let's say, okay, you're selling some 80-page single rule books, right? Now, how do most business models work, guys? Unless, guys, can you hear me? Can you hear me? Right? Okay, right? Unless you are producing the books in a factory, but in your own factory, how do we usually do all these online businesses and all, guys? We buy the product from somewhere and then we sell it at another price, right? That's how we do business. So let's imagine we are someone like that. I buy this book from somewhere and I sell it. Now tell me which method is better. I go to a store, I buy one book, I come home, I sell it. Again, I go to the store, I buy one book, I come home, I sell it, right? This is one method that I can do it. One by one, I can buy and sell, buy and sell, buy and sell, keep a small profit, right? Second method is I can go to the bookstore, buy 1,000 books, buy 1,000 of these books, right? Bring them home and sell them over a long period of time, right? First thing, when you buy in bulk, so what are we doing? We are buying in bulk also, right? You might get it for a cheaper price also. Which business module is better for long-term survival in the game? Which business module is better? First or the second? Second one. Why is it better? We are making a store of our products. I'm going to store a lot of these books and then I can sell them, right? With fluctuating prices and all of that, I can do that business nicely, right? And I can make a good profit. Same thing here. What is this glucose and what is this growth hormone doing? It is making a nice pool of glucose in the blood first, right? Otherwise, what can growth hormone do, guys? Growth hormone can tell whenever blood glucose is there, okay, go to the tissue, work. Whenever blood glucose is there, go to the tissue, work. It can do that. The second method that growth hormone is actually working is it's making a large pool of glucose in the blood, right? Collecting a large amount of glucose. And then IGF comes. IGF pushes all that glucose into the tissues. What is happening? Rapid growth, right? Rapid growth, periods of growth. Okay. This is how these two guys are working hand in hand. Did everyone understand this? Right? Give me a thumbs up if you all understood this. The most complex part for today is over. Right? All good? Right? Let me see your faces. Right? Okay. Right. Good. Right. Then guys, let's take a break and then we can dive into, we are done with the physiology. Now we just need to talk about acromegaly and gigantism. Let's take a small 15-minute break and come. Right. Is everyone back? All good? Guys, turn your cameras on. Let me see your faces. Right? So I will send a screenshot of that diagram that we drew in the group. Some students told me they didn't have time to write down everything, right? So I will send a screenshot of that in our WhatsApp group. Okay. In case you all missed anything, right? If you all understood, that's all I want, right? That's the main point I want. Right? Okay, guys. So we are done with the physiology. Now we'll go to the growth hormone disorders. We are mainly going to talk about what? Acromegaly and gigantism. Right? Acromegaly and gigantism. Right? A second, guys. Yeah. Okay. Right? Okay. Look at this. The first thing I want you all to know, guys. So growth hormone and insulin-like growth factor, now we know they function together, right? What I want you all to know, guys, right? Growth hormone, right? What did we say? The main functions is skeletal and soft tissue, skeletal plus soft tissue growth, right? Skeletal plus soft tissue growth. Then we also now saw some metabolic functions, Okay, we saw some metabolic functions as well. Okay, right? Now, here's what I want: growth hormone plus, you all can put in brackets, plus IGF. Both of these, IGF-1, they both work together, right? What I want you all to know now, guys, right, is this. Look at this. Guys, is there a delay between my voice and the video? No? Okay. Right. Just let me know. Right. Right. Look at this. This skeletal and soft tissue growth and metabolic functions, right? If there is an excess, right, what happens? These things also become excessive. Right? If there is an excess of growth hormone and IGF. Now, if this excess condition, guys, if It occurs before epiphyseal plate closure. If you all can write before epiphyseal plate closure, right? Epiphyseal plate closure, right? If that happens, guys, we call this condition gigantism. Gigantism, right? If it happens after the epiphyseal plate closure, after epiphyseal plate closure, right? This condition, we call it as acromegaly, right? Why this difference, guys? Now imagine this is a normal person, right? Imagine this is a normal person, right? If this soft tissue growth and skeletal muscle tissue growth and these metabolic functions, if they occur before the epiphyseal plate closure, what will happen? Bone elongation will be very large. So what happens, guys? They become giants. If you look at the same ground level, if this is the same ground level, these people are like this, guys, right? Giants. Okay, I don't know what I drew there, right? Okay, giants, right? Right? What happens, guys, if it is after epiphyseal plate closure, right? It's not the bone length that is the problem. It's the bone thickness. It's the bone thickness, right? So these people, you can draw something like this. Their face also will look a little bit weird, right? And their hands will look a little bit weird. Feet will look a bit weird, right? We will look at all of these, right? But they are the same height, guys. They are the same height as a normal person, not a problem with the height now, right? It's a more of a problem with the features, with the facial features, with the hands and everything, because the bones are thickening, right? Okay, this is what we call as acromegaly, right? Okay, now, okay, all good, written down. Now we'll look at the causes, guys. So what causes this condition for growth hormone to increase like this? Like this. You're writing, right? Okay, I see everyone. All right. Okay, right. It is. Okay. Now look at this. Now we'll look at the causes, guys. The etiology. What is happening here? Why is this happening? Why is this happening? First thing, guys, when you look at the etiology, right? Etiology, right? Okay. There are some, guys. There are some familial ones, right? These are basically genetic. These ones, guys, are very rare, right? So we are not going to talk about this. There is a genetic mutation called the AIP gene mutation, right? We are not going to talk about that, right? Please give me a second. This thing is changing focus. Let me. Give me 1 minute, please. Right, there we go. Good. Doesn't change focus, right? Yeah. All right. Good. Look at this. Familial one, we are not going to talk about, right? Familial one, we are not going to talk about. What we are going to talk about one is, guys, the sporadic one, right? This is the common one, right? Sporadic one, right? This sporadic one, guys, right? What can happen? Growth hormone can increase due to several reasons. One, right? We call this eutopic growth hormone. Eutopic growth hormone excess, right? That means from these normal pituitary pathways itself, growth hormone is high. From the somatotroph itself, more growth hormone is being produced, right? Eutopic from the same location, right? This is actually the most common type, right? What is the main cause here, guys? This is called a somatotropic adenoma, pituitary adenoma, a somatotropic pituitary adenoma, okay? A somatotropic pituitary adenoma, right? Okay, right. The second one, guys, the second one is ectopic growth hormone. That means from some other site, growth hormone is being produced. This one is, guys, rare, right? This one is extra pituitary causes. The example we have is, guys, carcinoid syndromes. Carcinoid syndromes, guys, especially they say of the gastrointestinal tract, right? Then there can be of the respiratory system. What are these carcinoids, guys? These are carcinoids are basically, they are basically cancerous lesions, right? Tumors arising from neuroendocrine cells, right? From neuroendocrine cells. So those cells, they suddenly start producing growth hormones, right? We are not going to talk about that. That is also relatively rare, right? Relatively rare. Okay. The third one here, guys, is even more rare, right? But we need to mention it because there can be, right, an increase, right, in, we can say, excess GHRH. So some problem coming from the hypothalamic pathways itself, not just the pituitary, right? Excess GHRH, growth hormone releasing hormone, is too high, right? Okay. Right. Okay. Then, guys, so this is the one I want you all to know. This is the one I want you all to know, right? Somatotropic adenoma. Now, here's the important thing I want you all to know here, guys, right? In this somatotropic adenoma, what can happen? This somatotrope is what kind of a cell? What kind of a cell is this in the pituitary? Acidophilic. It's an acidophilic cell. This is an acidophilic cell, right? Acidophilic cell. What did we say was special about these acidophilic cells, guys? They have the same cell lineage. Same cell lineage. So what did we say? They share the lineage with what other type of cell? Share the lineage with what? What? Sorry? With what type of cell? Not what type of hormone.
Lactotroph.
Lactotrope. Lactotrope. With lactotrope. They share the cell lineage with lactotrope. So just keep that in mind, right? Because what can happen in some of these cases, we can see prolactin also high. We'll see that in the diagnosis. Just keep that in your mind. Now we'll come to the clinical features. Clinical features, right? Clinical features. Guys, take a piece of paper and draw this fellow. We will draw. You all also can draw. Just draw now. Draw it like I'm drawing. There's a reason we are drawing it like this. Good art class for you all. Draw it exactly like I'm drawing, guys. These weird things, weird structures, we'll talk about all of them. Huh? Right, this is our acromegaly man. Huh? Acromegaly man. Right? Okay, draw this fellow. Oh, here, guys. Draw his teeth, but keep gaps. Draw it exactly like this. Okay. And then inside his body also, we will look at a few structures, right? You can draw the trachea, right? And the larynx there, right? Okay. You can draw the heart here. Right? And then you can draw the liver, the heart. Maybe I will draw it a little bit smaller. Otherwise, heart becomes too big. Why do I insist on your drawing these, guys? They stay, I don't know, at least for me, it helps to keep in memory, right? Most of my diseases throughout my internal medicine study, in my final year, when I was in final year, most of the diseases, I made a man, right? I always make a man, right? SLE man, ADH problem, SIADH man, right? Myxedema coma man, right? Helps to remember these things. And you can draw colon also, guys. A large intestine only, no need to draw the small one. Right? And somewhere in between here, draw pancreas. Pancreas, somewhere here. Okay. Right. Here, guys, on one of these fingers, draw a very tight ring. Draw a very tight ring. A very tight ring. Right. 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 Okay, done drawing. Let me see if you are drawing or not. Guys, keep your cameras turned on. Right. Done. Shall we? Huh? I will send a picture later, right? You all can draw later. Let's look at this, guys. Right? Look at this. Take one color, right? We are going to mark him basically in two colors. One, the external features, and the other problems inside the body, right? So we'll mark them in two colors. First, we'll look at the external features, right? What we see on the outside, right? Let's start off with the face, guys. Let's start off with the face, right? Here, look at his chin, guys, his lower jaw, right? His mandible, right? You can see it protrudes outwards, right? This is called what, guys? This is called prognathism, P-R-O-G, natism, right? Prognathism. This is called prognathism, okay? Bulging out of the lower jaw, okay? Prognathism. The next thing, guys, look at his lips, enlarged lips, right? Enlarged lips. Now, this is what some people do surgery also for, right? Enlarged lips, right? Okay. Then the next thing, look at this, guys. Look at his teeth. Look at his teeth. His teeth, guys, especially this is special for the lower jaw. Upper jaw also can happen, but lower jaw is more visible, right? Here, what you see is, guys, widened spaces between teeth. Spaces between teeth. Now, all of these happen due to growth hormone and IGF excess, right? Especially, guys, these widened spaces. Why? The gingiva, right? The gum area, they are going to become hypertrophied and hyperplasia, right? So these teeth, they start growing apart, right? Okay, so that is. Again, guys, inside, I did not draw the tongue. You all can put a arrow to the tongue inside, right? We'll imagine that the tongue is inside, right? Their tongue is also often enlarged, guys, right? So they have macroglossia. We call this macroglossia, enlarged tongue, right? Macroglossia, okay, macroglossia. Then look at this tip of their nose, guys. Tip of their nose. Now, if you all touch the tips of your noses, provided none of you all have acromegaly here, right? You might feel, first thing, you can feel the cartilage itself, right? These patients, guys, the tip area of their nose becomes very fleshy. We call this a large fleshy nose, right? Large fleshy nose. Why? Soft tissue accumulation, right? Soft tissue overgrowth, okay? At the tip of the nose, right? Large fleshy nose, right? The other thing, guys, look at this area. Let me draw it a little bit more clearly, right? Here, even in this side, right? And even in this side. This supraorbital ridges, guys, the supraorbital ridges, right? These are very prominent in these patients, right? So you can write that also down. Prominent supraorbital ridges, right? Prominent supraorbital ridges, right? You all can write it down. I don't have enough space there. You'll just write it down, huh? Prominent supraorbital ridges. Then the next thing, look at his forehead, guys. His forehead is also bulging outwards, right? His forehead is also, what do we call this? Frontal bossing, right? Frontal bossing. We call this frontal bossing, right? Bulging out of the forehead, okay? Then look at his earlobes, guys. His earlobes, usually they have enlarged earlobes, right? Okay, enlarged earlobes. Here, look at his mandible, guys. Here in this area, right? His mandible is also usually enlarged, guys. You can write that also down. Mandibular enlargement. Okay, mandibular enlargement, right? So these are some of the main facial features that you see on the outside, right? On the outside. We'll see some other things that are happening in the head area. We'll see, right? Then we'll come to the rest of the body, guys. We are still looking at the outside. Huh? Look at these, guys. We drew it like this. They tend to have, guys, thickened skin tags, right? Thickened skin tags. Why? Why? Again, due to soft tissue overgrowth. Their skin tissue, right? Their skin is overgrowing, right? So they have very loose, thickened skin tags, right? Okay. Now, look at this, guys. At the same time, if you look if you touch their hands, right? If you touch their hands or anywhere of their body, these patients, guys, you all can draw somewhere here, right? They have hypertrophy of their sweat glands as well, right? So they have increased sweat production, increased sweat production, and increased sebum as well, increased sebum. So they feel very oily to the touch, guys, right? They feel very oily to the touch. Now, when there is increased sebum, especially in the face, what do we get? What do we get when increased sebum is there? Yeah, guys, these patients, right, they tend to have a lot of pimples, right? Lot of pimples, right? Okay, again, because of the same mechanisms, sweat production and sebum is higher. Sebum is higher. Okay, right. Then look at these guys. This hand, right? This hand. What is it? Enlarged hands. We call these guys spade-like hands. Spade. You all know the spade. You all dig the ground, right? It's like a spade, right? The hands are very thickened and their bones, the fingers are very thick, right? Spade-like hands. Okay, spade-like hands. And how do these patients usually come, guys? Right? One of the first things they say is, right? I was wearing my ring for 20 years, right? I've been married for 20 years, wearing my ring for 20 years. Now suddenly it is tight for me. What is going on, right? Okay, so ring tightening, guys. This is one of the common complaints, right? Ring is something people almost always wear, no, guys. So when there is some sort of tightening, they notice that quickly. Okay, so they come with that complaint often, right? Ring tightening. Okay, right. Then, what about this guy? Look at his feet. His feet, obviously, we have enlarged feet. But what I want you all to focus here, enlarged feet. What I want you all to focus here is this part. Look at that part. Why did we draw it like that, guys? Right? There is something called increased heel pad thickness. Heel pad thickness. Right? The soft tissue in this area, right, increases to a great extent. Increase heel pad thickness. Okay, right? Is this clear? Right? These are some of the main external, guys. Apart from that, just for you all to know, now this can vary a little bit depending on what the patient's genetic background is like and what sort of a diet he is on. But in general, when we look at these acromegaly patients, what do you all think? Will they be very obese, very fat individuals? Or will they be like lean, a little bit muscular? What do you all think?
Muscular.
Yeah, these patients, guys. Yeah, that's why I didn't want to exaggerate this because this can be changed from person to person. But most of the time, guys, right? I drew these leg muscles like that. You all can draw some hand muscles also if you all want. Right? These patients are usually a little bit muscular. Why? In the mechanism we saw, protein synthesis is being stimulated, right, by both the growth hormone and IGF, right? And what did they have? They also had some lipolysis. So fat was also a little bit taken away, right? So because of that, guys, generally, write down. Generally, they tend to be muscular in appearance, right? Muscular. We call these guys, they have lean body mass increase. Lean body mass, right? Increased lean body mass, right? This is what they say, right? This is in general, lean body mass is increased. Okay, right? Right. Then, right. So those are the external things, guys. What you see, what you can generally assess in the patient, right? Then we'll go to some of these internal changes that are occurring. Now, we've talked about most of these metabolic things, but we'll add them to this picture, right? First thing, guys, we'll start from the top, right? One of the first things you all know, this is what is the main cause? What is the main cause? What is the most common cause? 90% of the cases is what, right? It's a somatotrope adenoma, pituitary adenoma, somatotrope adenoma, right? If there is an adenoma, right? Now, yesterday when we talked about even, not yesterday, sorry, day before yesterday, what did we say? Especially for this growth hormone adenomas, guys, right? Majority of them are macros. Majority of them are macroadenomas, right? when we take somatotrope adenomas, you all can write it down. Somatotrope adenomas, over 75%, guys, if you read Kumar and Clark, they say this, over 75% are macroadenomas. Macroadenomas, right? Macroadenomas, right? Macroadenomas. What does macroadenoma mean, guys? In size, they are greater than 10 millimeter in diameter, right? Greater than 10 millimeter in diameter. Now, look at this. If we have such a big thing growing in our head, right? Big thing growing within our skull. What is one thing that can happen? Intracranial pressure can be elevated, correct? Intracranial pressure. Why? This is a large mass growing, right? If intracranial pressure elevates, how do they manifest, guys? Right? They have severe headaches. Severe headaches, right? They can have severe headaches, right? Majority of the patients, right? We say over 75% macros, okay? Severe headaches. Then the next thing, guys, their eyes. Now look at this. Now this is where the applied anatomy comes in. Remember, we talked about on the first day about the sphenoid bone and where the pituitary is located. What is happening when there is a macroadenoma? What is one of the first structures to get disturbed?
Optic chiasm.
Our optic chiasm, right? Our optic chiasm. Look at this, guys. Let me just quickly go over that. Look at this. If these are our eyes, right? These two are our eyes, right? This is the lens here, right? These are our eyes, right? What happens is, guys, our optic nerve is in connection with the retina. It is something like this, right? You can draw this, huh? Take two different colors for those two, huh? Right? What happens? These medial fibers, they cross, right? And then they go, right? The other ones, they just keep going. Now, where is the chiasm? Where is the optic chiasm? Optic chiasm is this, right? Our pituitary is located somewhere here, right? These are pituitary, right? These are pituitary. Now look at these eyes, guys. Right? Okay, draw it, draw it. Okay, these are fibers from the optic nerve, huh? These are, so our optic nerve, it has the medial and the lateral fibers, right? From the retina, right? That's how they take up the neurons, bring the signals to the optic nerve, right? What is happening, guys? Right? If this is, I'll say this is the nose here, right? That's the nose. So anything in this area is midline. Midline. This is the midline, huh? Right? Look at this. The light rays coming from the midline come and strike this lateral retina, right? Okay. Same for this side. Same for this side. Light rays coming from the outside, from the lateral aspects, right? They come and strike the medial retina, right? Okay. I should cross it here, guys. Sorry. Cross it here, like that, right? Like that. Okay. They should cross at the lens, huh? Okay. They come and strike this medial retina, right? Okay. So now tell me this. I will draw the visual fields. What do I mean by visual fields, guys? This is how we as humans see. We as humans see, right? If I draw the visual fields, right? If I draw the visual fields, they're something like this. If light coming from this aspect, now if there is a pituitary adenoma, what happens? Optic chiasm is destroyed. Optic chiasm is destroyed. So as you can see, these red fibers, they are not going to bring in the signal, right? They're not going to bring in the signal to the brain. So what is happening? Light coming from here won't come into the brain. Light from here won't come into the brain. So if I were to draw this thing, if I say A, this is A, B, C, D, right? This entire, that's okay. Let me draw it like that. Out of A, B, C, and D, which visual fields will we not see? Will our brain not be able to see?
A and B.
A and D, right? This won't be seen. This won't be seen, right? This won't be seen. This is called, guys, this is on either side. Our peripheral vision is not there. Central vision is all right. So this is called bitemporal hemianopia. Hemianopia, right? Bitemporal hemianopia. This is also called what? Tunnel vision. Tunnel vision, right? This is also called tunnel vision. Okay, tunnel vision, because you can see only like a tunnel area. Okay, so this is the visual field defect here, guys. You all can write it here. Bitemporal hemianopia. Now, tell me this statement, true or false? Acromegaly patients commonly present with bitemporal hemianopia. True or false?
False.
True.
False.
True.
False.
Shashank, why are you saying false?
They typically present with the ring thing. And if for the bitemporal hemianopia, it has to be
Has to be a
macro, not
has to be a macroadenoma, right?
Yeah.
What did we say about 75% of the cases of acromegaly? They are
ectopic.
They are macroadenomas. They are macroadenomas. 75% of the cases are macroadenomas, right? So this is common, guys. That statement is true, right? Acromegaly patients, they can commonly present with bitemporal hemianopia. Okay, that statement is true, huh? Okay, right. Then we'll come to this respiratory tract, right? Look at this, guys. Now, when there is excess growth hormone, what is going to happen, guys? This laryngeal area, right? We have laryngeal enlargement. Laryngeal enlargement. So what will they have? They will have a very, very deep, hollow voice. A very deep, hollow voice. Write it down. I can't. Deep, hollow voice. Right? Deep, hollow voice. Right? Because their larynx is enlarged. Right? Thickening of their larynx. Right? Look at this, guys. Laryngeal enlargement. Right? Laryngeal enlargement together. Write this down. Put this laryngeal enlargement together with this macroglossia. What is going to happen, guys? They have an enlarged larynx. At the same time, their tongue is also enlarged. What is happening, guys? They get... Sorry? Okay. Right? Sleep apnea. Sleep apneas, guys. Right? Right? When they're sleeping, suddenly, right? They cannot breathe, right? And they wake up, right? This is obstructive sleep apnea, right? A cause of obstructive sleep apnea, right? So these patients can have sleep apnea as well, right? Larynx enlarged, at the same time, large tongue, right? So sometimes they can't breathe properly. Okay. Then, guys, look at this heart. We'll come to the heart. What is happening in heart, guys? This one is one of the major dangerous complications, right, in this disease, right? Okay, this is one of the life-threatening changes that can happen due to this disease. What happens, guys? First, there is cardiac hypertrophy. Cardiac hypertrophy, right? Initially, there can be cardiac hypertrophy. This is mainly, guys, initially concentric hypertrophy, right? Initially, they have concentric hypertrophy. Now, those who came for the cardiology module, right? Go back to your notes. Check where we talked about concentric hypertrophy and eccentric hypertrophy, right? Okay. Mainly concentric first. When there is concentric hypertrophy in the heart, what will happen to blood pressure? What will happen to blood pressure?
Increase.
Yes, right? They tend to have hypertension, guys. Hypertension. This is one of, at the initial stages, a little bit of raised blood pressure, right? Okay. As it progresses, guys, as the disease progresses, if you all came for my heart failure chapter, right? Can you all remember, after concentric hypertrophy, after a long period of time, right? Because this cardiac muscle is getting tired now of overfunctioning. What is happening eventually? What is happening eventually? Anyone?
Volume will accumulate.
Yeah, eventually the heart muscle starts dilating, right? Eventually the heart muscle starts dilating. We call that eccentric hypertrophy, right? There, guys, what these patients in a little bit of a later stage, they can present with cardiomegaly, right? Let me erase this eyeball a little, right? They can present with cardiomegaly, right? Cardiomegaly, right? Okay. Now this is not good, guys. Cardiomegaly, you all know, right? This can this can pave a nice road to heart failure, right? Then added to this, guys, because of this cardiomegaly, what happens? Coronary circulation becomes a little bit poor, so they can have ischemic heart diseases on top of this, and sometimes they can even have arrhythmias, right? Arrhythmias. Now this is the problem, guys, right? When we are assessing whom to treat, we have to consider we have to make a cardiovascular risk assessment for these patients. Okay, we will talk about that in the treatment. Okay, is this clear? Then look at this liver. What happens to their liver, guys? Right? Nothing. You all already know, right? A lot of abnormal functioning is going to be, all that functions that we talked about in the physiology is going to now keep increasing. Gluconeogenesis, all of those pathways, right, are going to increase. At the same time, liver tissue, right, is going to hyperproliferate, right? How are they going to come? Hepatomegaly. This is generalized organomegaly, guys, right? Especially organs like the liver, they can undergo increased size, right? Then here, why did we draw pancreas? Why did we draw pancreas? Tell me, based on the physiology that we talked about.
Diabetes.
Excellent, right? Why? What type of diabetes do you think? Right? Don't worry, diabetes will be taught A to Z. Just from the physiology that we talked about. Yes. Excellent. The insulin resistance, right? Insulin resistance. Why? We saw because of the fatty acids, there were some mechanisms which we didn't talk about, right? Because of those mechanisms, what happened? Insulin resistance to insulin increase. So this acromegaly, guys, especially when we consider growth hormone, it is called, you all can first write down diabetes, right? This is why we drew the pancreas, and especially this is with our insulin resistance, right? Insulin resistance, guys, this is type 2. This is called type 2 diabetes. Don't worry if you all don't understand this, especially juniors, right? This will be taught in depth, right? What this is, how this happens, type 1, type 2, what are the differences? We'll talk about all of that, right? Now, here, guys, because of this, growth hormone is given a special name. What is it called? It is called a diabetogenic hormone, right? Growth hormone is called a diabetogenic hormone. Why? In abnormally high levels, it can give rise to diabetes, right? Okay, type 2 diabetes due to the insulin resistance. Okay, right? Then one more thing, guys, we drew the large intestine here. Look at this. Actually, two more things. We'll look at this. Here, guys, inside the large intestine, I want you all to draw some polyps. Can you all see these polyps that I'm drawing? Yeah, you all can see, right? I want you all to draw some polyps, right? Now, polyps, guys, why do this happen? Again, due to the increased growth hormone, guys. There's excessive, unnecessary growth, right? Okay, from the mucosa, from the gastric mucosa, there can be unnecessary outgrowths, right? These are what polyps are. Now, the important correlate here is, guys, these polyps, right? These polyps, right? About 1/3 of them, about 1/3 of patients, if they have polyps, acromegaly patients, if they have polyps, about 1/3 of the patients, guys, they can progress into colonic malignancies. This is another very important point when we are assessing the treatment, right? Colonic malignancies, we have to look for polyps, right? Those who came from my GIT class, where did we see pseudopolyps?
Ulcerative colitis.
Excellent. That's all I want. Excellent. Good. Ulcerative colitis. Why? Why did we see it there? Why not in Crohn's?
TH2 mediate.
Yeah, Crohn's is TH2. Excellent. That's it. That's it. Thank you very much. I'm very happy. Right, let's move on. Students who missed the GI module, don't worry. Yeah, we are working on restreams. Don't worry. Right. Look at this. Then guys, just draw some bones inside this fellow. This last point, just write it down. Just draw a bone there, right? Inside. What did we say, guys? Under normal physiology. Under normal physiology, what happened to the bones? Bone mass increased. Mass increased, right? With the growth hormone, right? What happened? The size increased. Size increased, right? Now the size, we said it can be either of the two, elongation or thickness, right? We discussed the mechanisms. And then what is the other thing we said? Turnover. Bone turnover increased. Turnover increased. Now look at this. When these increase, this was in normal physiology. What happens when growth hormone is excessively high in this acromegaly patient? These ones become excessively high, right? Okay. And what happens, guys? What happens? These patients, first thing, when the bone sizes are very large, guys, what is just next to the bones? Our muscle and our other tissue, right? So there can be inflammation of the muscles when there's continuous growths of the bone, right? So they can present with myalgias, okay? Myalgias, okay? The other thing, guys, same way, arthralgias, right? Joint pains, right? Arthralgias, right? And when there is increased bone turnover, guys, especially if these patients are a little bit older, right? There is a risk of osteoarthritis. Okay, this is when it is pathologically high. Huh? Now that's what we are talking about, the disease in acromegaly, right? In normal physiology, these will increase a little, but doesn't cause these diseases, doesn't cause myalgias and arthralgia, right? It has to be pathologically high, like acromegaly, right? Okay. Is this clear? All good, right? All good, right? Shall I erase? Right? I will erase. If we'll finish the class, right? Let me erase this. Right? So if anyone couldn't write down today anything, just drop me a message. I will send some photos or some screenshots or something. Okay? Or I will find a note from a student who has completed and then send it to you. Right? Then, guys, we come to the diagnostic testing. So that was the clinical manifestations. Now we are coming to the labs, right? Labs, right? What can we look at? Okay, what can we look at? First thing, guys, in the serum. Now, what is the disease? Acromegaly or gigantism. Acromegaly is the main one we are focusing on because we are studying medicine here. In the serum, what is obviously the first thing that should be high?
Growth hormone.
Growth hormone, right? Growth hormone should be high. The problem is, guys, now what is the normal range of growth hormone? We said about 0.4 to 10.0, right? Micrograms per liter, right? This is the normal range. So it will be greater than this. What is the problem with growth hormone measurements? What is the problem?
It's pulsatile, so
yeah, it is pulsatile, and on top of that, what? Very short. Yes,
short
very
half-life.
short half-life. So this one, guys, we don't generally use, right? Not generally use, especially single samples, right? A single random sample is not generally used, right? Single random sample, we don't generally use. It is usually, it's useless of doing it, right? Instead, guys, what is the one of the best first test to do is our IGF-1. This is the one we talked about, IGF-1. Now you all know why. Tightly bound to plasma proteins. So half-life is long. It can indicate the previous, we said, about 20 to 24 hours, right? So it can indicate our previous day's readings itself, right? This one is more reliable, guys. Write this down, very important, right? The best first test, right? This is the best first test, okay? Best first test. This is needed for questions, guys. This is needed for your questions, right? Okay. Next one. Say another one we can do is, guys, what with regards to serum. Another thing we can do is a serum prolactin. We can look for serum prolactin. About 30% of the patients will show an elevation. Okay, about 30%, right? Not very significant, all right, but we can do it, right? Right. Now look at this, guys. The second, so this is, we put it as number 1. The second one, guys, right? Oral glucose tolerance, write this down, huh? Oral glucose tolerance test, followed by, or plus, don't forget to write this, huh? Followed by, right, a serum growth hormone measurement, right? Why I'm saying this, guys, because even for diabetes now in the upcoming chapter, we all will talk about the oral glucose tolerance test. There we do the oral glucose tolerance and measure serum glucose. Here we do the glucose tolerance and we measure serum growth hormone. Okay, right? So there's a difference there. Don't mix the two up, right? Look at this. How do we do this, guys? Oral glucose tolerance, we first give a 75-gram dose of glucose, right, to take via mouth, right? 75 oral glucose, 75 grams. Then you stay 1 to 2 hours, guys. This will depend on where you are practicing. In Sri Lanka, in most hospitals, we stay 2 hours, right? We stay 2 hours. You wait for 1 to 2 hours. And then in this case, after that 1 to 2 hours, we look at the serum growth hormone. Look at serum growth hormone, right? Serum growth hormone. Now tell me this, right? Go back, if you all don't remember, go back to your page of stimulatory and inhibitory factors. In a normal person, now we are talking, I'm asking about a normal person. In a normal person, if you give glucose, if glucose is given, what will happen? His blood glucose will increase. Blood glucose will be high. In a normal person, if blood glucose is high, what happens to growth hormone? If you all remember, tell me, or go back to your page.
Reduce.
Low. Reduce.
Excellent. Excellent. Why is it reducing, guys? Why is it reducing? What happened to the hypothalamic stimuli? Which hypothalamic nuclei? Which ones got stimulated? Which ones got, we all remember?
Periventricular stimulate.
Excellent. What about the other two? Arcuate and the? Yes, excellent. So the periventricular gets stimulated to produce somatostatin, right? So somatostatin comes, growth hormone up. This is what is supposed to happen in a normal person. What happens in an acromegaly patient? In acromegaly, guys, in acromegaly patient or gigantism, right? You do the same thing. You give glucose, right? Their blood glucose will increase, but despite their blood glucose increasing, their growth hormone won't reduce as expected. It will reduce. Here you can put about 3 arrows, right? In a normal person, it will reduce drastically. Here it will reduce, but to a very small amount. Because how we say it is, it never, what was the normal value, guys? 0.4 to 10. 0.4 to 10. In acromegaly patients, it can never be brought less than 0.5. Less than 0.5. In acromegaly patient, it doesn't drop less than 0.5. Okay? It will drop a little bit, but never goes below 0.5. Okay? Right? That is the important thing for you all to know. Now this value, guys, this 0.5, look at this. If you read different sources, you will get different, right? Harrison's will say 1. Kumar and Clark will say another one. Kumar and Clark says 0.3. I will tell you all the values. Kumar and Clark says 0.3. Harrison says 0.4. Davidson says 0.5. Right? So wherever you all are going to do the exam, choose that. Okay? I'm telling you all. But in general, it shouldn't go less than 0.5 in these patients. Okay? Right? Depending on your source, it can change a little. So just watch out for that. And depending on where you're taking your exams, follow those guidelines. Okay? Right. Then, so this one, guys, this test, this result is a confirmed diagnosis. This is a confirmed diagnosis, right? So what does this tell us, guys? IGF-1 is the best first test. What does that mean? This is the best screening test. best screening test, right? We do this first. We do IGF-1 first, right? Then to confirm the diagnosis, we follow it with the OGTT plus a serum growth hormone measurement. Okay, very important, huh? Very important, right? Okay, right. Then apart, so these are the main ones. These are the main ones. Apart from that, you all can put number 3. What can you do? You can look at their visual field defect, right? You can assess their visual field defect, right? Visual field, right? And the final one is, guys, you can do a MRI, right? You can do an MRI as well to look at the pituitary gland, right? To look at the macroadenoma, basically. Okay, right? But these ones are the main ones that I don't want you to forget. Okay, right? Then, guys, we come to the treatment and we are done, right? Did you write down? Right? Okay, look at this. Right? Treatment. How to treat these patients, right? First thing, write down, guys. Treatment, huh? How to treat them? First thing, write the therapeutic goals, guys. What are our goals? What are our goals, right? First thing, guys, we want, write this down. I'm not going to write everything. First point, right? Return of IGF-1 and growth hormone back to normal levels, right? That's the first goal. Return of IGF-1 and growth hormones back to normal levels, right? Okay. Second one, guys. Second one, increased quality of life. Why are we even talking about quality of life here? Why are we even talking about quality of life here? Huh?
Because a lot of deformities will already
Yes,
have been taken.
especially involving the face, guys. Let's say hands, let's say feet, you can put on a pair of shoes, but face, right? Face, there are going to be structural deformities. So you have to consider that, right? You have to consider that, right? Third thing is, guys, to reduce mortality. Mortality. Here, what are we assessing, guys? One is cardiovascular risk. Cardiovascular risk. Okay, that we talked about due to the complications there. And again, you have to assess for gastrointestinal malignancies, right? You have to malignancies, right? You have to look at all of these, right, to reduce mortality. Okay, here, guys, write it down in red. Treat everyone, treat all patients, right? Treat all patients except those with minimal deformities or is in very old age. Now, why we say very old age without giving an age number, guys, without telling greater than 60 or something, it is because this is a clinical judgment. This has to be made by the team, right? Okay, you can't just decide if someone is above 80 that you're not going to treat them, okay, right? So it has to be made, that judgment has to be made, right? So those are the goals. How do we treat? First choice, guys. First choice is what? Guys? Surgery, right? First choice is surgery. Unlike most of our other medical chapters where we leave surgery as the last resort, first choice is surgery, right? What is this, guys? We usually do something called a transsphenoidal. You all must have already talked about this a little, right? I think Sasanga mentioned this. Resection, right? I have put some pictures also, guys. You all can go through when you all are free. Huh? Transsphenoidal resection, right? Transsphenoidal resection, right? This is curative, guys. Huh? You can put it in brackets. This is curative, right? Curative, right? It can help cure the disease. Right? Now, look at this, guys. We said 75% of these cases are macros, right? So those kind of situations, guys, especially if it is a macro, right? You can do surgery followed by radiotherapy. Radiotherapy, right? Okay, right? Surgery followed by radiotherapy, especially if it's a macro. Because why are we doing this, guys? Why are we doing the surgery first? To try and what? To try and debulk the tumor a little. Now you all know if it's a macro, it's a huge tumor. So we do surgery, cut off a little bit, right? Make the tumor a little bit smaller. Then we give radiotherapy, right? And the radiotherapy will reduce the rest of the problem. Okay. So this is usually a debulk surgery, right? Okay, debulk surgery. Okay. Now look at this, guys. What is important for you all to know here? After surgery, guys, right? These are MCQ question, guys. Now look at this. I will put some questions regarding this chapter in our Telegram group. Attempt them, try them. Okay, try those. I'll put some very good questions. Look at this. What I want you all to know here: transsphenoidal resection as soon as post-surgery, guys. Post-surgery, once the surgery is over, post-surgery, right? Growth hormone levels return back to normal within 3 hours, within 2 to 3 hours, sometimes 3 to 4 hours max, right? Growth hormone comes back to normal, right? What do you think about IGF? How long do you think it takes? Huh?
More than 2 to 3 days.
Yeah, about 3 to 4 days, guys. Why? You all understand the concept, right? Because before the surgery, obviously there must have been some IGF in the blood. That stays for a while. That stays for a while, right? So 3 to 4 days, it will come back to normal, right? Growth hormone, almost immediate, guys. It comes back to normal very fast, very fast. Why? Pulsatile and short half-life, right? Okay. Right. The problem here. Now tell me this. Transsphenoidal resection is the choice of surgery. What is the complication? What is the complication? Yesterday, towards the end of the class, we talked about something. I asked you all a question, and some of you all got it correct, some of you all got it wrong. What did we talk about?
Hypopituitarism.
Excellent, excellent. The complication is, guys, hypopituitarism. Hypopituitarism. Why? Right now, we know this is a somatotrope adenoma, right? Does that mean no matter if you're the world's #1 surgeon, can you directly go and cut only the somatotropes? Can you directly go and remove only the somatotropes? No, you're obviously going to damage some thyrotropes. You're going to damage some corticotropes, right? You're going to cause some damage, right, to the surrounding areas as well. So it can result in hypopituitarism. Okay, just know that that is a possible complication. But this is the choice, guys. This is our first choice, transsphenoidal resection. Okay, right? Because this is curative, right? It helps cure the disease, right? Right. You all can keep writing. I will erase this. I don't have enough space. Second choice. Yes.
You wrote we we treat all patients except those with minimal deformities. Won't that lead to like increasing of like the symptoms with
No,
time?
that's the thing, right? That's the thing. You have to. So minimal deformities means what? Minimal deformities means first thing, externally their deformities are less, right? You have to make the assessment, guys. You have to look at you have to make a cardiovascular assessment. You have to look at their GI. You have to make all those assessments before coming to that conclusion. But chances are, if they are showing minimal external deformities, chances are those internal complications are also less, right? Do you understand? Because the more severe the growth hormone problem, the more severe the first thing, external deformities and internal complications, right? So you have to make the assessment. Just because they don't show anything, you don't say, okay, go home, right? You have to make a clinical judgment. You have to make a proper clinical assessment, because what happens if they look fine, but they are growing a GI malignancy, right? You will get sued, right? So you have to make the assessment, but that's for you to consider, guys, right? Those who with deformities, you can consider, okay, right? You have to educate the patient. You have to tell, we can do these tests for you if you want. There are some patients, guys, some patients, they will come and say, no surgery. I don't want to do surgery, right? Right? You will meet 101 type of patients, right? You have to explain the risks. You have to explain to a family member in those cases, especially if they're high risk, right? It's a lot of things to know. Right? That comes with clinical, with your clinicals that will come, right? As long as you all know your theory well, right? It will be easy for you to piece the stories together, right? We'll see, someday. Take you all on a hospital round or something. Yeah? Is someone saying?
Post surgery, will the external clinical features go back to normal? No, right?
No, that's a good question. Look at this. Very good question, right? In acromegaly, right? Acromegaly, post surgery, the hormonal levels can be brought back to normal, but the bony changes that happened, right? The thickened bones, especially if they had those facial features, those won't revert back, guys. Those won't revert back, right? So in the case, in some cases, might have to even go for what? Cosmetic surgeries, right? Sometimes cosmetic surgery as well, right? Have to consider all of that, right? It depends on the patient, guys, right? Say it's some television personality, they will go for it. They will go for cosmetic surgery after that. Okay. So those things have to consider. Acromegaly and gigantism, you can't reverse those changes, guys. Once you grow that tall, you're that tall. Once your facial deformities come, that's it, right? You can't change the bones. Good question, right? Let's go. Second line, guys. Second line. Second line is our medical, guys. Medical MX. Medical, right? What can we do here, right? The first choice is, guys, write this down, somatostatin analogs. Somatostatin analogs. What is the famous one, right? Octreotide. Octreotide. Okay? Octreotide. Octreotide. Okay. Somatostatin analog, guys. Why are we giving this? Now you all should understand from the physiology, right? Look at your hypothalamus, right? Get the picture. What does this do, guys? It helps reduce growth hormone and IGF. Correct, right? Helps reduce growth hormone and IGF. Apart from that, guys, it can help reduce tumor size. Tumor size, right? It can help reduce tumor size, right? And guys, what you can use this, right? You can use this for prior to surgery. Just write down prior to surgery. Because of this tumor size reduction, you can use this drug prior to surgery as well to reduce the tumor size, to shrink it a little bit, and then do the transsphenoidal surgery. Okay. So although these medicals are the second line and transsphenoidal was the first, right? You can use this octreotide to reduce the tumor size a little before the surgery. Okay. That's what I want you all to know. Okay. Right. Now, look at this, guys. Those who came for the GI module, right? And even if anyone else knows, somatostatin. We talked so much about this hormone, right? We talked so much about this hormone. Now, what is happening when you give somatostatin as a drug? It's coming from your GI, guys, into your blood. Now, hypothalamic somatostatin, it was there in the hypothalamus, so no problem. But when you're taking somatostatin as a medication, right, as a drug, what is going to happen? Some of those GI effects, right, side effects will be there. Some GI side effects will be there, guys. For example, right? For example, we can have some GI motility problems, GI motility issues. They can have diarrhea, guys. A little bit of diarrhea and malabsorption, right? And malabsorption. Now, right? Diarrhea and malabsorption. Right, abdominal discomfort, you can put all of those, right? Right, not very serious ones, but nevertheless, they will be there. They will be there. Okay, right. Then, guys, just note down somewhere in another color or something, the new second generation. Now, probably when you all are doing internship someday, right? The new one is, guys, pasireotide, P-A-S-I-R-I-O, right? This is the second generation. This is the new upcoming one. So sometimes maybe when you all are practicing, you all will have to use this. This one, guys, they say better action on reduction of growth hormone and IGF and better tumor reduction. Okay, better tumor reduction and lesser side effects from the GI. Okay, right? Just note that. Actually, no, guys. Just don't write about the side effects there. Side effect issue is a little bit controversial still, right? In Perera. If you read Harrison's, they say there is a small issue with that, right? It's a little bit higher than octreotide, the side effect profile. Just leave it. No need to write it. Right? Okay. Then, so that's the first one. Somatostatin analog. The other one. Now, what is high? Growth hormone is high now. So, what can we give? Growth hormone receptor antagonist. Growth hormone receptor blocker, basically, right? Growth hormone receptor antagonist. This is our second choice, right? Right. This is, guys, write this down. Pevysomant. There is a G here that is silent. Pevysomant. Right? The G is silent. Pegvisomant. If it's easier for you. It's okay. Pevysomant, right? Pevysomant, guys. Now tell me this. This is a common another question. I will put these questions. I will put these questions in the group. Right? Let's say we have a patient, we gave them Pevysomant. You looked at their blood after about, let's say, 2 months of treatment, right? What will you see with regards to IGF and what will you see regards to levels of growth hormone?
Growth hormone will be high and IGF will be low.
Excellent. Look at this, guys. This growth hormone receptor antagonist, it does not work on our pituitary, right? It does not work on our pituitary. What it does, it goes all around the body, and wherever growth hormone receptors are there, it will block it. It will block that receptor. So what is happening? There is no reduction in growth hormone production and secretion won't be reduced. So growth hormone remains elevated. But what happens if the receptor is blocked? Let's say one of the receptors are in the liver, right? If the liver cannot take up growth hormone, what will happen to IGF? IGF will be seen to reduce, right? IGF reduces, right? IGF reduces. Okay. I hope everyone, guys, I know there are juniors here, right? If you all have any issue with any concept, right? Don't be shy to message. So I know a lot of the boys message me and ask questions, right? Girls, I know a few, right? 1 or 2, right? No one else asks any questions. So I don't know if you all are scared of me or what, right? Just ask anything, get the best out of this program. Okay, right? Okay, COVID, guys, it's a blessing in disguise. So get the best out of this, right? We don't know how it will be 1 month from now. Once the borders open, we also don't know where we will be. Okay, so things can change. So get the best out of it. If you all have any question, message. Okay, I'm scared about the juniors, especially for second years, right? These are medicine concepts, guys. Okay, if you all understood the basics, no problem. Right? If you all have any issue, just drop me a message. Right. Third option. Third option, guys, dopamine agonist. This one, guys, is, tell me this, dopamine agonist. When will we use this on an acromegaly patient? When?
Prolactinemia.
Yes. If they have a mixed mammo-somatotropic tumor, right? If they are having hyperprolactinemia as well, this dopamine agonist will be very good, right? It will help reduce prolactin down, right? And it can help reduce the tumor size as well, because the mammo-somatotrope is just affected there, right? This is best for that scenario, guys. Okay, best for that scenario. Okay, then, so that is our second line, guys. Our final third line is irradiation. We are not going to talk much about here. The third line, you all can put third line. Third line, right? Third line. What is this? Irradiation, right? Irradiation, guys. Write this down. There is something special. I have put a picture, right? Stereotactic, ablation, gamma knife, right? Okay. This one, guys, I have put a picture in your skeletal notes. Go to your skeletal notes, right? Basically, what we do is, guys, right? The patient is sleep. The patient is lying down, right? Patient is lying down, right? Patient is lying down, and we are firing gamma rays at his brain lesion. right? We are firing gamma rays at the brain lesion, right? This one, guys, this can pinpoint, right? This can pinpoint even microadenomas. It can pinpoint and put the gamma rays. Here you will see like a big, I have put the picture. You will see like a big large helmet, and that helmet has tiny holes. Out of those holes only, guys, the gamma rays enter. Huh? Otherwise, what happens? And the other thing, so the patient is lying there, right? What if his head moves a little? What if he falls asleep a little? Huh? Big problem, but actually no problem, because we actually screw, guys. We use screws, right, to hold his head in place. They screw into his skull, right? Usually 4 screws, sometimes 6 screws, right? They make sure, because if the patient moves by a millimeter, right, something else gone. Okay, something else gone. So they screw this plate into the patient's skull and make sure the patient's skull is full. Most of the patients, guys, if you all have gone, especially students from China, you all will be taken to nuclear labs. At least for us, they took us. So we were able to see patients fall asleep, guys. Patients fall asleep. Huh? They fall asleep. So have to make sure that their head is held very stable. Okay. And the gamma, why they call this gamma knife, guys? It's not an actual knife, just as the ray goes and it destroys the structure, right? That's it. Right? Is this clear? Right? All good? All good. So today we had a bit of a long lecture, right? I wanted to finish this in one day, guys, because I heard students from some universities, they have their HSK things coming up. That's why I did it within one day, right? Was everything clear? Let me see some faces. Let me ask some students. Today's content, not very shallow. We went quite deep, right? Who is here? Nifla. Nifla, did you understand? Which year are you in? Which year? Just show me with your hand. 1, 2, 3, 4, 5. No? Okay.
Did you hear me? I said
No,
I'm
sorry.
in third year.
Third year, right. Okay. Did you understand
Yes.
everything?
Yes, I understood.
All good? Right. Excellent, excellent, excellent. Who else is here? Shabib, understood? All good? Thumbs up? Right. Okay, okay. Right. Who else is here? Keshini, understood everything? All good? Right, excellent. Mashi, all good? Which year are you in? Mashi Balasurya, which year?
Fourth year.
Fourth year, right. Fourth year, fifth year, I'm not really scared about. I'm scared about a little bit about the juniors. Right, anyways. So the students who answer, I know Tarinda, y'all are all good, right? Right? Okay, guys. So that's about it for today, right? We are done with growth hormone related disorders. The next chapter will be Sasangas. It will teach you all diabetes, right? I have one more chapter left towards the end, right? So I will meet you then. That's about it for today. If you all have any questions, don't hesitate to ask. I know some of these are research level stuff, right? It's all right. Ask, right? It's all right. Ask, right? Whatever is needed, I will let you all know, right? Okay. Right, guys. Okay, that's about it for today. Good night. See you all in the next one.
Thank you so much.
Right, no problem.
Thank you.
Right, you're welcome.
Thank you. Good night.
Right, good night.